Okay, well then let's call this meeting of the Joint Subcommittee to Study Mental Health Services in the 21st Century to order. This is our last year of work, and I want to make it a fulfilling year. I want hopefully to accomplish what we need to accomplish this year, and as much as anything, to put this house in good order for the permanent commission that will be established October 1. So we have a lot of work to do, and I hope we can get right to it. What I want to do today is kind of review what happened during this session. I want to take a look at the issues, some of the issues that we have to deal with this year, and then I want to develop a work plan for the coming year. I would anticipate that we'd have work groups as we have before, but there may be other ideas, and I certainly want to hear those ideas. So right now, to begin with, do we need to take roll or anything like that?
Yes, sir.
Okay.
All right. Senator Howe?
Here.
Senator Hanger?
Here.
Senator Barker?
Hello. This is George.
Senator Mason?
Here.
Delegate Hope?
Here.
Delegate Sickle? Delegate Price?
Here.
Delegate Bell? Delegate Ranson?
She's here.
Here.
Delegate Rush? Delegate Watts?
Here.
Senator Deves?
Here.
Mr. Chair, you have a quorum.
Okay. Unless anybody has something they would like to say, we'll start with an overview of the work on the 2020 recommendations, how they made it through the session from Sarah.
Okay. Good afternoon. I'm glad you could all be here today. I'm going to very quickly talk to you about our recommendations from last year. As Senator Deeds noted, we are in our 8th and final year of this 2-year study. And one of the primary recommendations that this group had last year, and we've talked about it off and on over the years, was to establish a permanent body to carry on this work. So Senator Deeds had Senate Bill 1273, which creates the Behavioral Health Commission. It's a legislative branch agency with the purpose of studying and making recommendations for the improvement of behavioral services and the behavioral health service system in the Commonwealth to improve the quality of and access to the full continuum of high quality services. The bill becomes effective July 1, so that commission will actually exist effective July 1. And this is the year that the transition process will happen. So setting up the staff of that independent legislative agency and transitioning the work this group has done to that entity. Other recommendations coming out of our work of last year, there were 3 others. The second recommendation was that the General Assembly should direct DBHDS to convene a work group to study and develop a plan for collecting and compiling data related to behavioral health and criminal justice. Delegate Price had House Joint Resolution 578, which required DBHDS to do just that, to establish a work group to study the feasibility of developing a secure, de-identified, renewable, and relational database of criminal justice, behavioral health, and other human services records to facilitate the development of more effective interventions. That resolution was agreed to by both houses, so we'll see work on that moving forward. Third recommendation was the General Assembly should restore funding for discharge pending jails. We heard last year that due to some of the budget disruptions, funding was paused. During the 2021 session, the Appropriations Act did restore $2.1 million in funding for discharge planning in jails for the second year of the biennium. That is the full amount that was previously appropriated for that time and then unallotted last year, so it has been restored. Finally, last year, the Joint Subcommittee recommended that this entity should continue to work on clarifying and reorganizing the statutes related to mandatory outpatient treatment. Delegate Hope had House Bill 2166 that we talked about in this group at the end of last year. He introduced and carried through the session. That bill made a number of changes to statutes governing mandatory outpatient treatment, the process and how that works. His bill passed and will become effective on July 1. It does have a delayed effective date. And it may be necessary or we may want to do some additional work around reorganizing some of those statutes for the purpose of clarity and ease of reading and use for those who have to implement the statutes. That's a project that could be on our work plan. There were a number of things that we talked about at length last year and in previous years. I've included those in the document. It's just a list of various things you might want to consider for your work. I'll come back to that and the bills that were referred to this body when we get to the end of the meeting. We can talk more about those then. So if anybody has any questions, I can answer them. Otherwise, we can move into the presentations as we have a very full agenda for the day.
Any questions for Sarah? Okay, Mike Tweedy from the Senate Finance staff is going to talk about the budget situation and how we made out from a budgetary standpoint during the 2021 session. Mike, it's good to see you.
Thank you, Mr. Chairman. Good to see you as well. Let me share my screen and hopefully this will work. Can everybody see that? Okay. So like I said, I'll go very quickly through the budget overview. On this first slide, just to give you a quick summary of, so far in this biennium, we've had 3 budget bills, which is one more than we would normally have at this point. So just a quick recap, the major investments in mental health came back in the 2020 session. It was nearly $135 million in community-based mental health funding was put in that time. But as y'all recall, then COVID-19 happened, and then to reconvene session, all of that money was basically unallotted or frozen until the General Assembly could then act upon it at a later date in the special session. That's where Chapter 56, those were the amendments to Chapter 1289. This is what came out of the special session last fall. The General Assembly did restore in the HHR area about half of what had originally been unallotted. And the majority of that was the mental health funding. That was a major focus in the special session, was to restore that mental health funding. And then where you get to kind of the end of this story is after this past session, there wasn't a tremendous amount invested or added in the 2021 session, but there was almost 20 million added, and a few of the remaining items that were originally not restored in the special session were restored in this session. So that's kind of like the story of the 3 kind of budgets so far. And I'll go through that as we go through the presentation very quickly. So basically this slide just summarizes kind of those major investments. And it shows you across the 3 columns, and you'll see this in the other slides. 1289 again is where we started, to where a lot of the mental health funding was frozen, to Chapter 56, where you can see it shows where it was restored back in the special session. And then, of course, Chapter 552, that is the chapter that we're currently under, that you all just passed and was adopted in the 2021 session. For STEP Virginia itself, that was really taken care of in the special session. The only thing added in this latest budget was about $700,000 was restored for administration. And this kind of goes back to the JLARC report that had recommended additional funds for DBHTS to more properly administer the program. So that funding was restored. So that's really the only kind of change with STEP Virginia. The permanent supportive housing and discharge assistance planning were all kind of restored back in the special session. Pilot projects with hospitals to reduce census pressure. So this is either to prevent them from coming to the state hospital or discharging from the state hospital. This was the idea of exploring different concepts with hospitals, which I'm sure at some point Commissioner Land can elaborate on. I know they've initiated some of these, and they definitely sound like some interesting things that they're trying. So hopefully that will help. But in the part of that was restored back in the special session in Chapter 56, and then an additional 3.75 million was just restored in this most recent budget. So that kind of puts the ongoing funding level at $7.5 million for that program. There was no change to the Virginia Mental Health Access Program that had been restored back in the special session last fall. And then Sarah already mentioned the forensic discharge planning in jails. The 2.1 million, that was the full amount of the second year. So that is fully restored in this last budget that was just passed. So that was kind of one of the last major pieces of what was still outstanding. And then one of the new items that was added was additional pilot projects related to dementia patients, something that was in the governor's introduced budget for this session, which was adopted, about $3.5 million. So again, that's really looking at dementia patients who really shouldn't be in the state psychiatric hospitals and figuring out other ways for where they need to be treated so that they can also help relieve that census pressure. So that was adopted in the final budget. Again, this screen, I'm not going to go over in great detail. The State Virginia funding status, like I said, the only change was adding back the administrative cost. But I will note that the only money that really wasn't restored were the first year amounts. But that's because if you think back in the fall in the special session, you really couldn't restore the first year amounts because almost half the year had passed. But pretty much all the second year amounts were pretty much fully restored. So really, I think the impact on Step Virginia is basically things were just delayed for about a year. So the next steps from this is really, I think, to evaluate. I think there were 3 services remaining: the psych rehab, care coordination, and case management that are still the 3 things left to be funded. I think in this, and I'm sure this will be an ongoing conversation with DBHCS as well, is to see how did COVID-19 kind of impact the implementation of Step Virginia, and how do these funding delays kind of impact us to get us to that final point where the program is fully implemented. I would expect at this point, when you get to the governor's biennial budget that he introduces in December, the expectation would be that hopefully he would include the final funding needed to fully implement it so that the program is fully funded by fiscal year 23. So that's, from my perspective, that's kind of where Step Virginia is. Just moving to other behavioral health funding actions, like I won't go into great detail, the Medicaid redesign of certain behavioral health services. I'm sure Dr. Ward from DMAS is on, and she's going to be talking more about that. Essentially, that redesign was delayed. You'll see that we did restore about $10 million back in the special session, and this budget, we just took $10 million out. It wasn't cut or anything. It was just an updated estimate of the cost of the Medicaid redesign. So really how they're going to, and I'm sure Dr. Ward will explain to you how they're going to roll out the services, that basically more the fiscal impact is more into the next biennium and less in fiscal year 22. So that's why you see the $10 million that we took out in this budget. But the Medicaid redesign, or what they like to call it enhancement, will still proceed, is still in course to proceed. The other items to note here, the behavioral health loan repayment program, that was a new thing that had been unallotted that was just restored in this recently passed budget. So that's the intention of looking at the workforce side of behavioral health and providing student loan repayment for up to like a 4-year period. It could be quite substantial. So hopefully this will be one more incentive to encourage people to enter the field of behavioral health and to help with those workforce issues. A few other smaller things to restore: transportation from state hospitals. So this is after TDO, the issue that if the person is transported far away, that how do they get back to their home? So those that money was actually restored in this budget. Back in the special session, some money for the Virginia Association of Recovery Residences. So these are the recovery residences for people with substance use disorder that had been restored back in the special session, and about $250,000 was added, kind of expanded in this past session. And then the Adverse Childhood Experiences Initiative with that DBHS was also restored in this. So pretty much everything originally projected 1289 was, for the most part, restored at this point. The mental health alert system, or the Marcus alert, if you recall, that was funded in the special session. The only addition there was about an additional $800,000 for some other administrative costs that DBHS will have to implement it. And the last 4 things you see on this slide are the 4 facility items. So kind of the 2 things that have not been restored. One is the additional cost for the expansion of the Virginia Center for Behavioral Rehabilitation. I think one reason is that census population can vary quite a bit. And so right now it's kind of, I think, a little bit lower than what was expected. So I think how that expansion is ultimately rolled out is certainly changing. And then for state hospitals, security staff, that was not restored. But the next one, the state hospital pharmacy cost, that was restored and with additional money to recognize additional cost. But that helps to address some of the cost issues at the facility. So that definitely will help them in the operation of them. And lastly, some additional clinical staff at the Commonwealth Center for Children and Adolescents was also restored. So other than some of this facility money, pretty much everything related to the community that was funded originally in the 2020 session was restored. Just some other budget actions. These are language items that were included in this budget to note. The temporary detention order evaluator work group that was originally established by a separate bill. Through budget action that is continued, and I think it reports back maybe December 15th of this year. And then a work group was created to evaluate the sharing of behavioral health patient records, so that they can, supposed to look at the processes and barriers to get patient information so that it can be shared better to better serve those people that are in crisis. It's also language added to develop options for the Virginia Treatment Center for Children, which is owned and operated by VCU Health. As my understanding through discussions in this past session, this language directs them, DBHs, to work with them to figure out how we can better utilize that facility to help relieve pressure on the Commonwealth Center for Children and Adolescents. And the discussion during the session, my understanding is VCU had some leadership changes at that facility, and definitely they seemed very open to kind of looking at this issue again. So that definitely seemed very positive. And then lastly, there was language added to require DBHS to report on efforts related to early psychosis intervention and coordinated care for children and adolescents, and to report back. And then another piece of language related to Chesapeake Regional Healthcare psychiatric beds. So they, this hospital in Chesapeake is planning to add 20 beds in the psychiatric unit. And if you recall, just like last year with CHKD was creating their own mental health hospital for kids. There was a lot of discussion about state support for this. So this basically kind of aligns this language with what we did with CHKD, was for them to work with the department and figure out, can the state come to an MOU with the facility to figure out, can they better help us with their own census issues with the state psychiatry. And based upon that agreement, the state could potentially be willing to put up some funds to support, just like with CHKD, even though that hasn't gotten to the point where there is any state funding for it, but it's kind of the same kind of potential partnership with Chesapeake Regional Healthcare. So with that, Mr. Chairman, that's kind of the quick overview. If there are any questions, be more than happy to.
Mike, do we know whether the King's Daughter Psychiatric Hospital has been built?
It's, Mr. Chairman, it's under construction. I think, if I recall, it's supposed to be operational by spring of 22, maybe. I don't know if Commissioner Land knows.
But the important part to me is that we're treating the hospital in Chesapeake exactly like we're treating the one in Norfolk.
Yes.
Yeah.
And my understanding is that there has been discussions between DBHDS and CHKD that, from what I've heard, have been very productive. So that could turn out to be a good partnership.
Are there other questions for Mike?
Chairman. Hope.
Is that Delegate Hope? Yeah.
Thank you, Mr. Chairman. I have a general question and more specific. General to Mike, all the budget language items that you laid out, do those report to this commission, or do they report to the General Assembly? Specifically, I was interested in the early psychosis intervention and coordinated specialty care. I mean, this is a pilot program. I think it's in 8 CSBs, and I think there's an opportunity here that certainly has proven itself in the places where it's being studied to be very effective. And I'm just wondering if this is something that the Deeds Commission, this commission, will get an opportunity to make a recommendation, or does it go directly to appropriations and finance?
I think, and Mike can answer this, but I think that any budget language is going to direct that the reports are to the chairs of finance and appropriations and the appropriations committee. And certainly if those folks choose to involve the commission, we can be involved, I guess, Madam Chair. But I think that's her prerogative.
No problem. You'll be involved.
Yeah, and Mr. Chairman, I'll just add, I mean, sometimes we do, most reports that are more budget related, yes, do just get reported to the chairs of the money committees. Some of these are not always that directly. I know one of these actually is to be reported back to this subcommittee. But But certainly any report, especially if DBHS is doing it, as a subcommittee, you all can request them to present it to you all. So that's entirely possible, and I'm sure they would be more than happy to.
Yes.
Yeah. Well, we could just pass the word on now to Commissioner Land that we are interested in that, as well as the geriatric, the placement of geriatric folks with dementia outside of psychiatric hospitals. I really want to know what that's going to do to our population issue, our census issue, and how much money we ultimately can save or redirect through that. Are there other questions for Mike?
Mr. Chairman, Watts.
Delegate Watts.
Thank you, Mr. Chairman. I was interested briefly in the background for the work group to evaluate sharing behavioral health patient records between community hospitals and CSBs. I remember 20 years ago trying to deal with this issue. What precipitated it now? And I ask that because I hope there actually will be a change in protocols.
Yeah, and Mr. Chairman, I don't know if you want to actually answer this, because I know you're more familiar with it than even me, but yes, I think it's those same issues that are still occurring today. How do we, are there ways to further reduce those barriers while still maintaining, of course, the privacy of people's,
It's
information?
A terribly complex issue.
Yeah, it's just a complex issue, and I think I don't know if one specific thing precipitated it. I think it's just that it's an issue that is still there, and I guess it's time for a fresh look at it.
It's an ongoing issue from the beginning of our work, and frankly, it involves a lot of federal stuff that we're just not able to control. Federal law we're not able to control, but to the extent that we can, it seems that the sharing of information with providers anyway is beneficial to the patient.
Mr. Chairman.
Madam Chair, yes.
This brings up a topic actually that I was going to bring up at the end, but if you'll indulge me for a minute. The letter you forwarded to us from the sister of a man with mental illness really captured me. I mean, it was so gripping and so upsetting. And so much of the problem was because of HIPAA, in my opinion, and inability of people to communicate to assist this man who clearly needs some help. And I wonder if we shouldn't be pushing to change HIPAA at the federal level. We have an office up in DC. I've never figured out what they do, but they're up there. And they're supposed to be liaisons with the federal government and our representatives. And I have been wondering if perhaps we should be pressuring them to get involved in this.
That raises all kinds of issues. About 2014 and 2015, I spent a little bit of time on Capitol Hill, and I didn't find much appetite among either Democrats or Republicans at that time for significant changes to HIPAA. That a lot's changed since 2014, 2015. And the personalities have changed. So that could be significantly different now. It might be worth exploring.
Mr. Chairman, Watts.
Delegate Watts.
Following up, although maybe, again, this should be part of a different discussion. Certainly my experience over the years on this is a lot of its interpretation of HIPAA, and that a solid study looking at what the practices are in other states as far as need to know. I think there are significant barriers that could be addressed in Virginia by responsibly looking at the legal issues and any case law, et cetera, about need to know. And I would just also add on this that this is another place where jails need to be involved, because we still have the situation of an individual being taken to jail and perhaps sent to the community hospital, et cetera, et cetera. So I hope we do take this on, even without the emphasis on changing federal law, but just looking at how federal law has been interpreted.
Well, I don't think that's a bad idea, because I think that HIPAA can be read strictly, narrowly, or broadly, and
Right.
There are plenty of examples of states doing all sorts of different things, and it might be worth considering putting together a group of 2 or 3 of our members to kind of take this on over the course of this year. It's something we can talk about toward the end of the meeting. Are there other questions for Mike? If not, let's hear from Commissioner Land, who will give us an update on the work of the Department of Behavioral Health and Developmental Services. Commissioner Land.
Hi, thank you so much. Heidi Dix is going to share her screen for my presentation and advance the slides. So, okay. So Heidi, you can go to the next slide. And thank you, Mr. Chairman and members of the Joint Subcommittee, for inviting me to join you here today. We've discussed at length over the last months and the last times that I've come and spoken with you about some of our huge system priorities, such as transforming our crisis system, about our pandemic response to protect both staff and patients in the state facilities and in the community, about implementing STEP Virginia and Bravo, which is the new name for behavioral health enhancement. We have a third name. Some of the other speakers that are coming behind are going to discuss these things today. And so I'll be talking about a different topic, but my omission of these important topics from the presentation, I hope you don't feel like that, but I feel like that diminishes their importance. We want to be able to come potentially and have the opportunity to cover these topics in depth at our next meeting with you, as they are essential to implementing an effective community-based system. And so hopefully we will be able to come at your next meeting if you have some room on the agenda for that. So today I will be focusing on specific issues at our facilities. And unfortunately, we'll share some things that may not be too easy to hear for you. I'm going to share with you an update on the census challenges at our state hospitals that they're facing, and which remain one of my top and our agency's top priorities. We've been working on this issue for years and years before I came, and the picture just looks bleaker, not better, I'll have to say. So I'm going to talk about some of the areas of greatest concern and where we're examining some additional solutions. And I'll share the key initiatives to help, like expanding the contracts with our private providers in Virginia, addressing our geriatric population, accelerating the state hospital discharges, and reducing our extraordinary barriers to discharge lists. We'll be working with the administration to offer solutions that are patient-centered, fiscally responsible, and that will continue modernizing our system. And we want to work closely with you and the subcommittee to refine these proposals where they're developed, because these are issues that are now very urgent, and we need your help to enact both meaningful and enduring solutions for the Commonwealth. Next slide, Heidi. So this is, we're going to talk about the census and how dangerously high it's been, but wanted to just remind that as the COVID numbers continue to trend down and as our vaccine availability continues to increase, we are hopeful, of course, that the most lethal weeks of the pandemic are finally behind us, and wanted to share that the number of positive COVID-19 tests in our facilities has been in the single and low double digits since March 26th. So we're at 14 today. We were in single digits until the weekend at our facilities, but that over 1,700 DBHDS patients and staff have recovered from COVID over the last 13 months. As you'll see on the left, among the 8 mental health hospitals, 6 have had periods of admission closures based on VDH recommendations for outbreaks. And on the right-hand side, you can see that it's only Eastern State and Western State that have had the size and the space flexibility to stay open during their outbreaks. So they've been able to cohort patients and manage to maintain operations and not have to fully close their facilities during their outbreaks. And you can see, even without those bed closures and periods of lower admissions, the annual census at those 2 hospitals is extremely alarming. And the reason it's alarming is that when a hospital is full, it means that there are no beds left at all. So staff may find space for a patient in a day room or in a hallway, on a cot, on a mattress on the floor, but there's no privacy. There's a lack of adequate staff to maintain constant observation, and it makes patients vulnerable to victimization, and there's a lack of recovery-oriented treatment in these scenarios. So such improper placements push census levels above the 100% mark.
Mr. Chair.
For example, okay.
Mr. Chair.
Senator Barker.
Yes, I have a question or comment and question for Commissioner Land. There are 4 of the hospitals where you're showing several hundred more, or about at least 50% more discharges than you're showing admissions for this fiscal year. And in reality, if that were correct, then if you started out with 300 patients in the hospital and you now have 300 more discharges than admissions, you no longer have anybody in the hospital. So those numbers don't appear to be right at Central State, Eastern State, Piedmont, and Western State.
So that left-hand column of the admissions are the TDO admissions. The discharges are all of the discharges, and that includes our forensic, which are not considered TDO admissions. So that includes all of the discharges. But I was coming to that.
Okay,
so
well,
I'll talk about
what would help would be to have the admissions and discharges be from the same category of patients, rather than having the admissions be just the TDO and the discharges being everybody. So,
okay. So what we were attempting to show there is the churn, the significant churn that we experience in the state hospitals, because it's a lot of work to do an admission and a tremendous amount of work working with the CSCs and other providers in the community to do the safe discharge, get safe discharges out. So that was trying to give you a feel for just how many patients we have to do admission and discharge planning work on. But did want to let you know that the highest capacity that we reached during the past year was at Piedmont Geriatric, and they were over 112% of capacity. So we think that our newly launched electronic health record is going to enable us to begin discharge planning on the day of admission. It does have required documentation that includes assessment of where the patient's going to be discharging to and what the needs are going to be, so that we go ahead and begin to do that on the day of discharge instead of waiting till the patient's ready for discharge. So I wanted to share that with you, that our new EHR was going to be a good help to us, we believe, and want to also emphasize that these staff at these facilities have really done a remarkable job. They've been managing COVID, this extremely high census, and have implemented a new EHR in all 12 of our facilities during the pandemic. So incredible public servants, and just wanted to share that information with you. Heidi, next slide. So CCCA also has challenges. Our admissions did trend down. Did somebody have a question?
Mr. Chair, I've got a question. I'm happy to wait until the end if that'd be better.
Bell, go ahead.
Right. Hi, Madam Commissioner. So you have given, or your predecessors have given us the following information, but I don't remember the answer. And in any case, it probably would be helpful. In terms of bed space, one person there for a whole year takes up 365 bed nights. But if you have three nights per stay, you can have 100 people sort of cycle through. Can you give us some idea? My memory is that you always said an average is not very helpful because you have some people there for a long time and a large number there for a much shorter time. But some idea of how long people are staying, and use whatever criteria are the most helpful or descriptive.
Yeah. So when you look at the average length of stay, it's around 86 days, which is extremely long. But we do have patients up over 1,000 days or 1,400 days. So we have a big mix. But we really have seen since bed of last resort legislation that there's about, and I've got it on another slide, but there's about 66% of our patients that are staying 30 days or less. So we're really cycling faster now than we have in the past, because currently we're doing more of an acute short stay patient, and we are staffed, our processes are all based on a long-term chronic population, and we really haven't adapted those processes. And that's something that we're going to work on this year and so you'll be hearing a lot about that. just to share that with you. Does that help?
It does. Thank you.
Thank you. Okay. So we saw a downward trend that was pretty significant during the last quarter. So that April, May, June of FY 2020 due to the stay-at-home order. And we typically see that over the summer and during the holiday break that our volumes go down. But we are seeing, since we started the reopening, steady increases in FY 21. And we're only able to staff 30 of our 48 beds currently. When we had our outbreak there in September, we lost a lot of staff, and we're working really hard to restore those staffing levels. We were actually down around 24 patients when we came back online. And so we've really been successful over the last several months to do some active recruitment and retention efforts. But we are anticipating a surge in admissions in September, again, once we return more to in-person learning. So we're working really hard to prepare for that. So, for example, last week we signed an emergency contract with CHKD, who we talked about during Mike's presentation, for diversion from CCCA. They're going to be adding about 10 beds in their ED for a bridge. They're going to do observation and stabilization treatment for 23 to 48 hours. And then they have a bridge clinic in their outpatient psychiatry office. And so we're hoping to really get some good success there down in Region 5. And then we're actively working, again, as Mike mentioned, with the VTCC folks at VCU and their new leadership, who are just being fantastic partners to find other opportunities there for them to help us with the CCCA population. And we're meeting biweekly, so we'll be staying on top of that as well. Heidi, next slide. So you've seen this slide before many times, and it gives you a view of how the TDO admissions are trending, both in the private hospitals in that navy blue section and our state hospitals. And
because that is the one.
Did somebody have a question? Okay, maybe it wasn't. The number of TDOs across the state has gone down since fiscal 19, and it's safe to assume that COVID really played a role in that. And following the Western state expansion, there are no more plans to add beds to the state hospitals. The replacement at the Central State Hospital facility is planned to open with actually fewer beds than it has now. So the place where there is room to grow beds is in the private sector, but there is simply no ability for the state hospitals to continue along this trajectory. We're continuing to see increases in the percentage of the TDOs that we're taking and the number of TDOs that we're taking. And so we really are going to be looking for solutions and trying to work closer with those private providers on what we can do. Next slide, Heidi. So staffing shortages really are critical at this point, but we're not alone. Healthcare employers everywhere are feeling the effects of exhausted staff who are leaving employment that are following over 12 months of pandemic-related stress and just the fear that they have of the virus. And combine this level of burnout with the high risk in the state hospitals, the patients, and the risk that they put the staff at are low pay, and then a serious situation truly does emerge. We have over 1,000 state facility direct care vacancies, and we've had that since March of 2020, and it's actually been growing and exacerbated by the pandemic. And to put that in perspective, there are roughly 5,500 full-time positions when we're fully staffed at the 12 hospitals. So over 1,000 plus vacancies is large, very large, and very makes our facilities overwhelmed, our staff overwhelmed. And at the same time, again, we're operating very close to or over 100% of capacity of bed utilization. And we're only funded to operate at 90% staffing, but with our current vacancies, we really are operating at 60 to 75% staffing. And you can see some of those significant vacancies. On the top row, you'll see our direct care staff and what those vacancy rates look like. And then on the bottom are our providers, our psychiatrists and if we have internists for some of our geriatric units for their medical needs, you can see that it's really critical. And notably, vacancy savings are not able to be realized because of the expensive staffing contracts and mandatory overtime. In fact, our staffing contracts can be up to 3 times more than regular employment costs. So we've been working extremely hard for several years to assist our facilities with recruitment and retention. And I'll just say personally that the activities that we're taking here at DBHDS are on par with efforts I've witnessed in the private sector. So we're really trying everything we can think of. So we're using staffing contracts. We have a large number of international nurses, locum tenens. We do national advertising and a lot of other strategies. But it's a steep uphill climb, and we're not making the progress that we need to make. So we're not only challenged in our facilities by the difficult job descriptions, the high-risk job descriptions, but also that direct care compensation falls well below market value, and so it's just not competitive. So we're looking at options, including raising salaries to the market rate and other ways to attract and retain employees. And also, as the patient acuity goes up and TDO admissions, again, as I've discussed earlier, they continue to cycle more rapidly now at the state hospital. Adding security staff and other safety strategies could be a way to just decrease the daily risk that our employees are facing. So staff and patient injuries are very frequent, and we must do everything we can to protect both the staff and the patients. So we'll be looking at some of those strategies as well. Heidi, next slide, please. Okay. So again, we are engaging every strategy we can to address the overall census. You'll see on the slide some of the contracts with other providers, and it's just a snapshot of some of the ways that we're contracting with, including the new ones for FY 2020 funds for step down and diversion contracts. We've confirmed existing agreements and developed 20 new agreements to address census, and wanted to point out a couple of things. Last Friday, we put out an RFP for those dementia patients that need either long-term care or RFP or an ALF services. And so that solicitation, we're hoping we had several out-of-state providers and in-state providers we discussed with them and actually got technical assistance on the RFP. So we feel like that we will get some proposals from the solicitation. Sometimes we put out RFPs and we don't get anybody to respond. And so I think this one is going to really be well received. We also, have put, you can see a large number of them there. And with the VHHA pilot programs, we're very close to signing the contract with Carilion Clinic. And we have Riverside Behavioral Health and looking at WellPath recovery for an option for our NGRI population. So looking for some good things there. And so we're really hopeful about these new contracts, but we are aware that some of these efforts in the past have been a tremendous amount of work that has had minimal impact. As I mentioned, sometimes we do a lot of work to do an RFP and we don't get anything back. But we continue to be very interested in expanding these contracts to help divert and step down these admissions, and really for children, adults, and geriatric patients. So we're really hopeful that we're going to get somewhere. We're really close to signing some really, those pilot projects in particular are very in-depth and comprehensive and really looking at doing more of a continuum. So it's really great news. Next slide, Heidi. So I know that, wait for her to catch up. Heidi, next slide, please. Thank you. So I'm sure everybody probably has seen something very similar to this picture, either on your TV, in the news programs, or in the paper, or on the internet. So, and as you saw in the former slides, that we're on a unstable trajectory, but because there's really no bed availability, and some individuals are experiencing admission delays while hospital staff work to free up beds. So with the exception, though, I want to just remind everybody of the COVID-19 emergency protocols from the governor. We are not denying admissions to state hospital, but it does take time to ensure that every discharge is safe before we can free a bed for a new admission. and state hospital staff are working closely with the community partners all the time to free up a bed. And it's really no small task to make sure that they have everything that they need so that they're safe when they go into the community and don't bounce right back. So many of our current delays are even more complicated, again, because of COVID-related infection protocols. And that's going to remain in place until the pandemic is declared over. And then those ripple effects that happen when we have a delay, they can't be alleviated, and they begin to worsen. Some of the backlogs in the emergency departments and tying up more law enforcement time to transport people to treatment, that's really been an issue. And I know we're going to hear more about that later in the agenda. So, but we understand the frustration and want to, say that we get it. We're trying, and we're going to continue to work on it. So we're very concerned about the time these delays are costing law enforcement departments, particularly in the rural areas. And I know, again, everybody's been hearing about the frustration with the situation. DBHDS believes, as it is advised by their OAG, that we're following the code for bed of last resort correctly. But the ECO and TDO process is an extensive and complicated part of the code. And there are some places that seem to be open to interpretation. And one of the things we'd like to do is to try to clarify any ambiguity, particularly surrounding the custody and executing ECOs. And again, we're working with the administration, law enforcement, and providers to explore ways to address these delays. And we'll continue to work on those, just as you suggested. Chairman Dean.
I appreciate your attention to this issue. In rural areas where you might have one or two deputies at most on a duty shift, this is causing an incredible loss of manpower and sacrifice of public safety. And so I hope that you can work with the administration and with law enforcement and maybe some of the members of this commission to come up with some recommendations. And if we have to take further action, I think we will.
Yeah. Okay. We're on board to do that work. We are.
Mr. Chairman.
Delegate Ranson.
Yeah. Thank you, Mr. Chairman. Commissioner Land, I appreciate the fact that we're going through COVID right now, and certainly everything that they're doing. But these issues were going on pre-COVID. So whatever is going on with the ECO and the TDOs were happening before this. And, my plea to you is, particularly, I represent an area, I have 6 counties. And there are times when there is only one person that's working, covering a huge geographical territory. And that one officer is sitting in an emergency room for 2 days. He has to take over for another officer. I mean, I know I've emailed your office a couple of times on 3 or 4 different instances where this has happened, where I live with 4 different sheriff's offices. And again, this was going on pre-COVID. So my plea to you is to please try to work with the CSBs and law enforcement to try to figure out this issue. Because it's not just about law enforcement, it's the patient that is sitting in the emergency room having a mental health crisis, and we're not meeting their needs. They're sitting in the emergency room having a severe breakdown, and we are not helping them at all.
Yeah, that is an issue, and I'm working. My whole team is working. We meet regularly. I do think that the private providers need to be included in that as we do these meetings, because we should be getting stabilizing treatment on these patients who are in an emergency medical condition in those EDs instead of them not getting any treatment. And so if, those are some things that can help with the situation while we may be delayed. But when we say that we're delayed, we will divert to another hospital until we're at 100% capacity at every single one of our facilities before we delay a patient. And so, we're trying to do everything that we can. That's why I want to talk about some of these other issues today, because if we can speed up our discharges and get patients out, it opens us up bed capacity. If we can get dementia patients that don't belong in a state psychiatric facility, then we free up beds in our state facility. And there's things like that that we can do that are just key to just operating appropriately that will really help some of this. And so I'm hopeful that I can share those and that y'all will support them and that others will support them. Any other questions before I go to the next slide? Okay, Heidi, next slide. So alternative transportation is now available statewide. And so in March, the alternative transportation became available for both adults and children statewide, so 24/7, 365. And of course, these are for services for people that are experiencing a behavioral health crisis who are under a TDO and are clinically assessed to be appropriate for such transportation, that they are not so assaultive aggressive that they are going to need to go with law enforcement. So our services rolled out starting in October of 2019 and ending this past month with the rollout of services, as you can see, that blue arrow on the right, in Central Virginia in early March, and with Children's Services and Adolescents statewide on March 15th. So we're really proud of this. And our contractor G4S has completed just under 2,300 safe transport statewide. And the average trip statewide was about 190 miles round trip. And these efforts, we figure, have saved about 5,000 hours of law enforcement time on the transport. And we just expect these numbers to continue to increase now that we're available statewide and awareness of the program is growing. But as it is now, authority to operate alternative transportation can only ease law enforcement's burden for the transport itself, not for staying with the patient in the ED during, they can't sit with the patient in the ED during the ECO period, even though such a custody transfer would be better for both the patient and the officer. So we are looking at opportunities to expand this service to make more of an impact during the ECO period as well, which could take a significant burden from law enforcement. So we're hopeful that maybe we could get some expansion of the service and make a bigger impact. Heidi, next slide. Wanted to talk a minute about our finding solutions for patients with dementia. And this is one of the key initiatives that I'm looking at to reduce the census pressures. And as many of you are aware, we actually have had a significant increase in geriatric admissions over the recent years. And again, when geriatric beds are over census, the hospital must look for availability in the adult units. While we have had to put patients on cots in the day room, we do not do that with geriatric patients. They have a lot of additional comorbidities, medical comorbidities, and that would not be able to manage them in that situation. But that does reduce our capacity to be able to admit adults. And so one of the significant challenges we face is that 22% of the geriatric TDOs have a primary diagnosis of dementia. And our current code in Virginia, the definition for mental illness includes dementia, which is not a mental illness. And assisted living and memory care units are more appropriate sources of care for the dementia patient. Wanted to also share that about 51% of the extraordinary barriers to discharge list includes individuals in need of assisted living facility or nursing homes. And the services do exist in Virginia that more appropriately serve people with dementia who are in state geriatric beds, but we really need to be, those services need to be developed and expanded so that we have the place and the competency, the placement opportunities and the competency of the staff to manage these patients, because they do have associated behaviors. Some of the solutions that we're working on is we've initiated a pilot with Mount Rogers CSB that's in Southwest Virginia to provide support to nursing facilities taking older adults with behavioral health challenges. It's a company called Valley Health, or a unit called Valley Health. And we've already, in the last couple of weeks, we've sent 13 state hospital patients for admission since March 16th, and none have come back. And they are they have a 46-bed unit that they're fixing for us, and eventually are going to go to 60 beds. So that's going to be very helpful for our geriatric population in that area. We also, as Mike mentioned, had the $3.5 million appropriated for the diversion and discharge of individuals with dementia as a pilot. And so we released the RFP for that last week, as I mentioned earlier. It also, that budget item also included language for a work group to identify existing services for individuals with dementia in the community and make recommendations to improve the quality and availability of the care for those living with dementia. There's a Northern Virginia RAFT program that also was advised for us to look at to see if that might be something that we could expand to other parts of the state. And so we'll be also looking at that particular model of care. Heidi, next slide, please. Another of our critical initiatives is going to be expediting discharges from the state hospital. These are folks that are clinically ready for discharge and are just being maintained in a locked facility, sometimes way past their ready for discharge status. So as I mentioned earlier, our current process is designed to support individuals who have long-term stays at state hospitals, but 2/3 of the state hospital admissions, about 66%, are currently discharged within 30 days. And that average length of stay has really fallen greatly because we now have more acute patients with shorter stays after the bed of last resort legislation. But we need our discharge processes to be adapted for the short stay population when it's needed. We did have Senate Bill 1304, the 2021 session, created a work group that has VDHDS, the Virginia Association of Community Service Boards, and other stakeholders that are going to review current discharge procedures, both the hospital and CSB staff responsibilities in the process, and identify barriers to timely discharge for those that are clinically ready, as I said. It's also tasked with providing these recommendations by September 1st of this year, so we'll make sure that that happens. And the implementation, again, of that statewide electronic health record is going to really assist us, I think, by helping it begin our discharge planning on the day of admission. And it's expediting the discharge process to keep up with the TDO cycle is really a change in business practice for us, but even more, it's going to harness the ability of our EHR to detail patient needs, communicate more efficiently, and adapt to current demands for the patients. Next slide, Heidi. I don't like the look of that graph on the left, but that's our current look at the EBL by month since last July. And you'll see on the right that we've got the primary barrier to the discharge, and it's sorted high to low. So you'll see the largest number are, again, no willing provider for our patients that need to be discharged into a nursing home, ALF, or other supervised residential, and then the NGRI process. And then we've got patients that are awaiting discharge. Their date is scheduled. It may be that they have a bed, but it's not going to be available for 2 weeks, or they have, something like that it's scheduled, and we know what it's going to be, but it's going to be a long time. So we need to work on how do we, become more flexible and agile to be able to get services developed so that they're available when they're needed. We have next awaiting completion of CSB tasks. We have guardian barriers. Maybe we're waiting on a circuit court hearing or things like that. So these are some of the bigger barriers. You'll notice down at the bottom, some of the things that used to be higher on the list, we've really had great support to get funding to support. So the DB waivers, the permanent supportive housing, and those types of things have really come down to very low numbers because we've really put the attention on them and got the support that we needed to make that happen. So again, just for those who may not remember, these are patients that have been ready for discharge at least 14 days. So it's not that they just became ready, they've been ready. And many of them stay on there for years. I did want to mention, we did, and I mentioned this last time we spoke, that we started a work group in April last year to really start focusing on these. And we've had 909 discharges from the EBL list since last year in March, when we started at the beginning of April 1st. And so So you can tell that Virginia needs more community services that facilitate these safe discharges and from state hospitals and other inpatient settings. I mean, I know the private facilities also have issues. And we're continuing to address these barriers. And we do need ongoing support of DAP funds and to look closely at the NGR process within our agencies and other agencies. And so this is going to continue. Mm-hmm.
I think some of the smartest money we've spent has been the investment we've made in long-term supportive housing. And mm-hmm. I'm pleased to see some marriage of the numbers down here, but I want to know if you're able to follow those dollars since the last 4 or 5 years we've made it a priority and determine how much of that money is helping with the extraordinary barriers list.
We can get that information, put something together for you and share it with the committee.
I appreciate that. Are the folks that have been there more than 14 days and ready to go home, are they shifted to one hospital or do they stay throughout the system?
They stay where they're at.
Okay.
Mr. Chairman.
I'm sorry, Delegate Sickles.
I didn't mean to interrupt, Mr. Chairman. I wanted to ask the Commissioner about I don't think I might have missed it, the auxiliary grant. And I believe we boosted that a little bit, but if you need patients that can go to assisted living because of dementia and they can handle dementia and ALF, tell me how you see the future need or what you'd like to see for the auxiliary grant.
So we did get an update to that. What we were seeing was that an ALF would not take a state hospital patient that needed an ALF level of care on the auxiliary grant, and we would have to pay with DAP. What we've been trying to do is to do an auxiliary grant and then supplement it with DAP, so it doesn't have to all be DAP, so that we can make our DAP funds go further. But we're gonna continue to need an ALF level of care and the auxiliary grants going forward. I'm hopeful that the update will help a little, but also we've got this RFP, so some of those ALFs may be able to, send a proposal in response to the RFP and be able to, maybe have a supplemental payment from us that accept the auxiliary grant at the higher rate and go ahead and accept our patients, because then they would be, they get more patients if we've got a contract with them. They're guaranteed patients to come up, because we've got lots of patients at the facilities. We can fill them up.
Mr. Chairman. It's Janet.
Yeah, Senator Howe.
I am trying to noodle through the first two reasons. Is part of the reason there's no willing provider for 51 patients that they have gone through the NGRI process and people are frightened to take them?
So it's not that they've gone, the NGRI process is the second one. The no willing provider, there are certain facilities that just because they've had a stay at the state facility, the stigma of that, they don't want to take them. We send extensive referral packets that have lots of the nursing notes and documentation. And so they fully see the behaviors and they see what types of medications that they're on and that sort of thing. And many of them do not want to manage that acute a patient, that aggressive a patient. Yeah.
Yeah.
If they've been assaultive and aggressive to staff and other peers, they're going to be very concerned. And they really aren't staffed to do the, safety partners and things like that, the one-to-ones at these ALFs and long-term care facilities. So really what we need is to improve the competency of the staff. And like the one that I was talking about, the pilot out in the Mount Rogers area, CSD's area, we've put 2 LCSWs into the facility. And so they're able to do interventions and activities and, crisis plans and all of these. And they're working with the staff on how to manage the patients. And it's really, educating them and building that competence and let it so that they can safely manage and support them and maintain them in the community. Because if you don't, all they do is they get placed, and then as soon as something happens, they drop them off at the ED and say they can't come back, and then you've got a problem and they're back at the state hospital for, 8 months, 10 months, 12 months, while we try to find somebody else to give them a chance. So that's what's happening.
Thank you.
Okay. And so, Heidi, next slide. We're really just down to, talking to you and letting you know that, as you can see from the slides, we haven't slowed down at all during the pandemic. Quite the opposite. We're still right up there at 100% or more. We're really trying to do everything we can in our power to solve these difficult challenges, and we're grateful for the resources that we have received, and hopeful for more resources to address these challenges. And we'll want to work very closely with you on some of these challenges, such as code language clarifications and resources surrounding issues such as staffing, our dementia patients, and the EBL. They're not going to be easily solved, and they can't be solved without your help. And so, again, thank you, Mr. Chairman. Thank you, everybody on the subcommittee, for inviting me. And any other questions, I'll be happy to take them.
Thank you so much for being here, Commissioner Land. Let me ask you, we started down the course several years ago of, I think, radically remaking the face of services through our Community Services Board with STEP Virginia. Do you have a plan for the final implementation of the final steps of STEP Virginia?
So we will be, of course, it'll be the governor will make this, and his administration will make the decision on what goes into the budget. But of course, we're going to be, asking, for those last steps to be funded. But we're still involved in all the planning and everything, because we have to be ready when and if we get funded. We want to be approved and ready to go.
Okay. Are there other questions for Commissioner?
Mr. Chairman?
And Delegate Price.
Yes, thank you. I appreciate lots of information that we just got, and I'm not sure if this will be part of the Commission's discussion for our work plan. But as you were listing out some of the significant issues, let's say like with the staffing issue, do you guys have exit interviews or anything that we could know what some of the rationale is? Because, I guess you're coming to us for some answers. And so I think I need a little bit more information on why some of these things are happening, if the goal is for us to be able to have legislative or financial fixes. And then also, this might be a question for staff, but just wondering if in any of these points, if money that we're going to be getting from the American Rescue Plan could help with some of the things that are going on. And I think that's probably, we can discuss that later, but just wanted to throw those out for conversation.
Sure. We do exit interviews, so I'm sure we can get you, a breakdown of what the top issues are. I know that the safety, there's a lot of assaults, a lot of injuries to staff, and I know that the pay is not competitive. And we actually have the Mercer data, which is a national company that does payroll. Looks at the salary and compensation review across the country, and particularly we got the healthcare one, and it's broken down for every one of the categories of employees. And so we can see where we're at versus, nationally and on the eastern side of the country, so that it gets pretty relevant. So we can definitely give you that information.
Delegate Price, at one point, I don't know if this is still the case, but several years ago, we basically toured a lot of the hospitals in our system. And I know that at Central State Hospital, for example, and the Northern Virginia Institute of Mental Health, the police were called nearly every day for assaults on other patients or assaults on employees. This is dangerous, hard work, and the workforce shortage we deal with is across the private sector too. It's not just the state hospitals. It's probably more acute in the state system. We have to take a look at better ways to protect our employees and to pay them better.
Yeah.
Mr. Chairman.
Senator Mason.
I'm sorry, did I interrupt someone else?
No, it's okay. You go ahead.
Thank you, Mr. Chairman. Yeah, that's why it's concerning that the only thing that wasn't reallotted was the security money for the hospitals. So something we should think about. But thank you, Madam Commissioner. The age-old problem, no willing provider, of course, which we're trying to and need to continue to work on. But earlier during COVID, you told us the NGR process had either stalled or had been slowed down dramatically because of COVID. Have we worked through those issues, or are we starting to, or where do we stand in that effort?
We're getting more open and able to do the passes that are required, but there's still people that are not wanting, to either to go or for people to come. So if you have someone who may be going into some sort of housing situation and they need to go and stay overnight, it may not be that they're willing to have them come in because of COVID until everybody is vaccinated.
Thank you, sir. Thank you, ma'am.
But more and more are, so we are getting some passes done. So, it's not completely shut down like it was.
Are there additional questions for Commissioner Land?
Mr. Chair.
Delegate Bell, is that you?
Yes, sir. May I return to the issue we talked about briefly now that she's finished her presentation?
Sure.
Madam Commissioner, this issue, I'm just always interested in the idea that how long people are staying. The ones that you say are ready to be released but are hitting these extraordinary barriers, do they include people that have been there for a very long time? What I mean is, a 365 night person, or are they more the short stays, or is it just all over the place?
So, it's all over the place, but remember 66% of our patients are leaving within 30 days, but they can still be on the EBL because they may not have needed to be there but 7 to 10 days. And then they don't leave. And so they end up on the extraordinary barriers list. We're looking at maybe, while it might initially increase the number of people on the EBL, is reducing that, because one of the problems is if you're not focusing on them until after 14 days after they're ready to leave, then you're extending it, whether if you did it at 7 days or 3 days and you started focusing on them once they are way past discharge date, which I still think is extreme at 3 days. I wouldn't want my loved one or myself in a state facility for 3 days longer than I had to be, or 7 days longer than I had to be, or 14 days longer than I had to be. So, what I would like is for patients to be out, us to work on their discharge plan from the day of admission and be ready, everything in place, so when they're ready for discharge, they leave. That's my goal. But we have to, it's a lot of work, and it's a total change in the culture and the processes that we have in place. And so that's what it's going to take, though, is that focus on getting the plan developed and setting the appointments, getting the medication supply that they leave with together, getting their belongings together, making sure that we have transportation scheduled to pick them up. All of those things have to be, it just takes effort. And so we'll be talking with the CSBs and work on that work group and figuring out how do we do that better. That's what we're going to do over the summer. So.
Thank you.
Well, I think we've asked our questions. Thank you so much, Commissioner Land. And I'm likely, I think we're gonna appoint a group of legislators to meet with you and the law enforcement community and others to try to figure out the sheriff's issue. But we have an awful lot of work to do this year. Thank you so much for your help.
Thank you.
Dr. Ward, you've got the third name for your program for Medicaid enhancement, I guess. And
I do indeed, and I'm here to tell that story today.
Okay, thank you. Welcome.
I'm going to share my screen now. I want to make sure I get the slideshow started. So I want to confirm, are you all seeing the notes page or the slideshow itself? Because we're on Zoom, so I can only see one thing.
I see a DMAS Behavioral Health Update 2021 Advanced Proactive Evidence-Based Solutions.
And is that taking up the full screen?
No, I think we're on the notes because we also see your name in the next slide.
Thank you.
There.
So that's where I have to. do this. I believe.
That's it.
Good. Now I can't see you at all, so that's all right though. So oh, are you still here?
We're still here.
I apologize for my technical difficulties. Can you see it now?
No.
Let's see.
So the shared screen went away. I think if you just do it within the Zoom, we should be good.
I'm attempting. Okay.
You are currently back on the notes page.
Dr. Ward, it's Sarah. If you go to your display settings, when you changed that to the
swap,
yeah, we could see just the slides when you do that. You won't be able to see us, but we could see just the slide, and I think that's the view you want.
Does this look better?
Yes.
That's it.
All right.
There. Perfect.
I promise I have that PhD. It's just not in Zoom. Though I'm surprised I don't have an honorary one after this year. Thank you, Madam Chair and Mr. Chairman and all the members of the committee for having us here today to give you an update overall on DMAS's behavioral health activities. I know specifically you're very interested in hearing about behavioral health enhancement, which, as several of you have noted, has a new name, and I'm going to tell the story of that name today. I've brought a couple of my esteemed colleagues with me today. So typically I come here myself, but over the last year, I've worked every day with two incredible social workers, Ashley Harrell and Laura Reed, who really are the right and left hands of our behavioral health operation. And I wanted to include them today because they're so central to the success of everything that we've been working on. And I'd like for you to get to know them a bit and for them to be able to tell you about the hard work they've been doing. So we're going to start today by talking a little bit about priorities for DMAS in terms of behavioral health in the coming year. And then Laura is going to give an overview of our Project Bravo and where we are at since the last time I came and spoke with you. And then Ashley Harrell is going to give some updates on the arts program, which are particularly timely given the ongoing opioid epidemic and actually the worsening of the impact of that epidemic over the course of COVID. So, just want to underscore that despite all of the efforts that DMAS has undertaken during COVID-19, Project Bravo, or as you've known it, behavioral health enhancement, remains an agency priority and fits in, very well with the other priorities that we have in mind on our docket, including improving overall access to care for our growing numbers of members, our focus on maternal and child health, on health equity principles, and the addition of adult dental coverage this year. So some of the priorities that we've had within behavioral health are all too familiar to you, the major initiative being our Project Bravo implementation. And so I want to take a moment just to acknowledge the new name, the new moniker for this initiative, and explain that, in its prior iterations as redesign and enhancement, these were during different phases of the proposal for this initiative. And as we came into full fruition and we're so fortunate and grateful to be re-allotted funding for the initiative, and it really came to a reality, as we brought all the stakeholders back together and we began implementing, we really wanted to do something to make this our own and to kind of emphasize the values behind the initiative. And one of those ideas that we had was to name this project in honor of Dr. Hughes Melton, who was really one of the major supportive forces in the launch of this entire vision and idea. And as many of you know, Dr. Melton was an Army veteran. He was a pilot. And his call sign when he would fearlessly fly his tiny plane into the Atlanta airport was Bravo. And so as he is kind of flying this forward for us, and we're following in his memory and his honor, we've named the project Project Bravo, which stands for Behavioral Health Redesign for Access, Values, and Outcomes. And so we're working on a logo for that, and it's bringing us a lot of inspiration and meaning as we move forward and carry this into fruition. As part of Project Bravo, there was also some budget language added that mandated a managed care organization resolutions panel, and we have started that group and have begun working on some resolutions with our stakeholders, and Laura Reed is going to speak more to that. Ashley Harrell is going to be giving an overview of some of the activities of our Support Act grant team. We have brought in nearly $5 million in grant funding from the federal government to undergo this supportive effort around building capacity for substance use disorder workforce. And so we'll be speaking about that. We also have been very concerned about therapeutic day treatment as the year has progressed, as schools were shut down, as youth were moving away from those services. And so we know that that has been a priority for many of you and those that you represent, and of great concern to the providers. So over the last year, we've really done a lot of work around digging into some of the issues that we see with that service in the long term. We've been doing monitoring of utilization of the service across the pandemic, as well as other paired services that serve a like population. And I've been working on developing a training, which I'll be offering to both providers and MCOs kind of as a level set as schools go back into session around medical necessity criteria. And from a clinical perspective, what we might expect to see in terms of mental health problems as kids emerge from their homes and are integrated back into this kind of complicated world that they're coming back into. So how to identify kids, how to think about who is the best fit for TDT, and how to assure that MCOs are on the same page with providers in terms of all of those variables. So that is something I've been working on over the last month, in between working on all these other initiatives, and I'm hoping to launch it in the next few weeks. We also have been working hard as subject matter experts within the other agency priorities, including the implementation of our Medicaid enterprise system. So we have multiple vendors that we consult with regularly as part of the implementation of that project. Including we are about to put out an RFP for a service authorization vendor. And on all of these other agency priorities, we serve as subject matter experts to help with planning for special populations. So we've had our eye on, and you have seen this, but it is an updated utilization slide of what our community mental health and rehabilitation services have looked like in terms of utilization over the course of the last couple, 18 months or so. So this spans from July 2019 to our most recent estimated update in December of 2020. So you can see illustrated here that there was, some slight downturn in the overall general trend around the onset of the pandemic, though we did not see the type of drop in utilization overall that we saw in physical health services during the pandemic. And so that's just to illustrate that we are continuing to watch this as time moves on. And many of you may be familiar with what has happened to TDT as well, that we were watching this and looked at this data closely during the session and presented it. But as of June of 2020, we noted that among providers that offered TDT prior to COVID-19, that the number of TDT services provided declined by 68% as kids left school and schools were shut down. But we did see a number of intensive in-home services increase 81% amongst the same providers in that cohort. So what that cohort analysis indicated to us at that time was that kids were moving out of TDT into intensive in-home services during that period. We have seen those trends reverse over time, where the amount of kids using intensive in-home has not stayed stable at that rate from what we can tell right now. Sorry, I can see the sun is in my eyes. And we have seen some TDT tick up just a little bit over time, I think probably as some of the schools have gone back into session this spring. But we haven't seen it, come roaring back. And it will remain to be seen which way the providers move as schools go back into session. So we are continuing to utilize all of the data that we have to try to monitor that process. And again, I mentioned I'm going to be offering that training to do that level set and kind of get everyone on the same page about this service and its intended use. We have also seen, significant use of telehealth within the behavioral health area, and we've had tremendous tremendous feedback from our providers. We had 646 providers participate in our more recent telehealth survey, indicating that most of them, so about 82% of them, saying they have what they need to do telehealth. The challenges are largely on the member end, that the members don't always have what they need to complete telehealth visits. And that's no strange phenomenon to you all. This is in many ways related to lack of broadband or cell service. Some of it has to do with devices. But the devices, there are some routes through the MCOs or enhanced benefits that people can obtain these. Some providers have even gone out of their way to supply telephones or other telehealth devices to the members. But the lack of broadband, particularly in rural areas, is a real barrier. We have seen that providers have noted higher rates of participation in sessions. So that's one of the great strengths of telehealth, that, some of the things that hold people back from participating, like transportation and childcare and all of these issues of getting to appointments, have been lessened during this period of telehealth. Another bright spot over the last period since I've talked with you last is a really incredible demonstration of interagency collaboration that has been building for some time, but is relevant, I think, to the interest of this group. We've been working across the child-serving behavioral health agencies, so DMAS, DBHDS, Social Services, Office of Children's Services, Department of Juvenile Justice, and even VDH have all been sitting together and created a governance structure for a center for evidence-based center of excellence, which has a hub set at Virginia Commonwealth University. Michael Southam Giroux, who is the chair of the psychology department at VCU, is the director of the center. And these are the center's activities are currently being funded by DBHDS in part, but are hopefully also going to be funded by other agencies as the center's work becomes relevant to their interests or their activities. One of the really central things that this EBP Center is going to be doing is creating a credentialing repository so that the providers of the evidence-based practices across all of the different payers and funders will have a central space where their training and certification for these evidence-based practices will be held, which will create some efficiencies that we don't typically have in state government, where providers, funders, MCOs can all go in and see that information at once and not have to rely on complicated data exchanges. It will be an encrypted site. This is really critical for assuring that we have some smoothness in the process and that all of those providers who go through all these different funders don't have to keep submitting all of these materials to many different people. So very excitingly this summer, one of the things that we're doing to really support our system, our workforce, and our localities is we've all joined together with the University of North Carolina Chapel Hill's National Implementation Research Network. And we're going to be holding these evidence-based practice Are You Ready events at the locality level. We've partnered with localities to sponsor these. We have 5 different regions. Localities develop teams across folks from their communities to come together to have facilitation, which will now be over Zoom, And we'll be just talking about what does it mean to offer evidence-based behavioral health services in your locality? What would it take to do outcome assessment? How can you best understand the cultural or community needs that you have and pick the right evidence-based treatments for the best fit? So it's going to be, I hope, a really invigorating and exciting opportunity for the state to work really closely with locality teams and for us to get to know one another and partner together towards moving forward many of the great initiatives that have come through and out of the Deeds Commission. So I'm going to hand the Zoom microphone over to Laura Reed, who is the Senior Advisor of Behavioral Health at DMAS. And she's going to talk a little bit about all the amazing work that she has done on Project Bravo over the last few months. Laura is the co-lead at DMAS on this project and has been doing a fantastic job of organizing all of our many project teams. So Laura, take it away. I will run your slide.
Thank you, Dr. Ward. Good afternoon, everyone. My name is Laura Reed, and I'm excited to tell you about our progress in implementing Project Bravo. You all know and have seen these slides before and really have championed and really supported us on our journey, and we appreciate that. Really, our goal is to really shift our system from something that is reactive, crisis-driven, and high cost to a system that is more proactive and preventative and really meets our members in their community and provides treatment in our community. It's going to be an iterative process, a phased-in approach because we can't do it all at once. And we're really excited that we're going to be going live in our first phase in July. Dr. Ward, you can push the slides forward for us. And really what the first phase looks like is 6 critical services, which are actually 9 because crisis includes 4 services in and of itself. But these services really, we chose these services really because they are going to be supportive in what Commissioner Land was speaking about in terms of really bringing individuals out of the hospitals and back into the community where they can, receive treatment and really also help prevent our members from even stepping foot into a hospital. And so the first 6 services are a partial hospitalization program, which is a highly structured clinical program that really is slightly less intensive than an inpatient program. It is less than 24 hours, but really combines a lot of interventions. It's a very highly structured program and really can be used either to prevent hospitalization or as a step down from acute hospitalization back into the community. Intensive outpatient is similar, but a little less intensive. Instead of 5 to 6 days a week, it's 2 to 3 days a week. And again, really a great combination of services as a step down from hospital or prevention as well. Assertive community treatment is an evidence-based service that is a highly coordinated set of services that really is a team of individuals, medical, behavioral health, case managers, rehabilitation professionals that really work as a wraparound service for our members in the community with complex needs and serious mental illness. And then we have 4 crisis services, and that's mobile crisis, community-based crisis, 23-hour bed observation and residential, which we are really going from 2 critical crisis services to 4. So we are increasing our service array in the crisis, the service array in our crisis services to really meet the individual needs of our members. And then there is multi-systemic therapy and functional family therapy. And these are evidence-based programs that are community and home-based and really serve youth that are at risk and involved in the juvenile justice system and really have great outcomes in terms of reducing the need for residential care. All of these services serve to increase our continuum of care, decrease reliance on acute hospitalization, and really help our members receive services in the community. Next slide. This is just a quick glance at what our initial budget was in terms of before COVID, which was a little bit over $24 million. And then we realized a savings of about $10 million. And that's really due to the pandemic changing up our timeline slightly and really will not impact our ability to implement these services to their fullest as we intended originally. And so our current budget allocation was a little over $14 million. And the plan right now, and you're on track to do so, is to go live in July with the start of assertive community treatment, partial hospitalization program, and intensive outpatient. And then in December, we will be going live with multi-systemic therapy, functional family therapy, the four crisis services. So that's really what our timeline looks like right now with the pandemic. Next slide. We have been working for almost 2 years, and we've accomplished a great deal. Started with many, many work groups. They continue to meet, continue to provide us feedback. We've completed a rate study. We continue to align with key state initiatives, such as Stop Virginia and many other initiatives. The public health emergency impacted our timeline slightly, but we have our 8 project teams up and running, which I'll talk about in a little bit, and are on schedule to implement phase 1 on July 1. Next slide. You probably can't see the type on this slide because it is so small. But this is our high-level timeline and what we've accomplished so far. Our team structure and project plan were finalized in November of last year. We had a kickoff where we started our 8 project teams. We re-engaged our work groups. We began our MCO resolutions panel, which I'll talk about in a little bit. We have submitted our state plan amendment to CMS and are awaiting feedback from them. MCO contract changes, the behavioral health service administrator contract. We've added some new services into those contracts, so they are ready to go July 1. And we are knee-deep in really developing our policy manuals and our regulations around these new services. And actually, our policy manual was posted last Friday for public comment. So we're excited to see what our stakeholders' feedback they have for us. We have DBHDS has begun provider licensing of these new services. And I know that's a heavy lift for them, and we really appreciate the hard work that they're putting in and that collaboration there. We've submitted and put out several bulletins to our stakeholders around timelines and what's going on so that they're informed. And we are currently developing data dashboards that hopefully will be able to provide us sort of real-time data on claims and utilization around these services. And then come June, we'll be doing readiness reviews to make sure that MCOs and the VHSA are ready to process claims for the new services. And then the 3 new services will go live in July, and then we will repeat the process in the summer and the fall for the services that go live in December. So this is just a quick visual of what our project team structure looks like. We have 8 interagency project teams that include representation from DMAS, DBHDS, all of the MCOs, and the BHSA. They begin in December, and our Bravo team is really the central coordination team that includes representatives from DBHDS and DMAS, and really support all the project teams and the service-specific work groups. We also have external work groups that are up and running, our MCO resolutions panel and our newly formed racial equity work group, which actually their first meeting is tomorrow afternoon. And really all of these teams really serve and work collaboratively to inform the implementation of Project Bravo. So a little bit about our MCO resolutions panel. We want to acknowledge that we have budget language mandate to incorporate an ongoing panel to address provider concerns, really regarding the actions and management of behavioral health services of the MCOs and the impact this may have on the implementation of Project Bravo. We wanted to give you a high-level update on the progress of this panel. Our first meeting was held in December and included cross-divisional representation from DMAS staff and all of the provider associations. We have established a collaborative protocol for how associations can bring trend-level data and concerns to the panel on a bi-monthly basis. And in the off months, DMAS works collaboratively with all of our divisions work collaboratively with the MCOs to resolve the identified issues that the provider associations have brought forth. What you can see on your screen is an example actually of a survey that Virginia Association of Community-Based Providers did with their members to to identify overarching issues that they were experiencing. And then they provided that information to the panel, and we are working together to resolve those issues. This is also a public meeting, and so we record this, and it is posted to our website. And the next slide gives you the link to where you can find that information. And I'm going to hand it over back to Dr. Ward.
Dr. Ward, you're on mute.
You're on mute, Dr. Ward.
The phrase of the year. So I can hit pause here if there are questions germane to that initiative, or we can move forward. And actually, here I'll come present on all the activities of the arts program over the last year.
Are there any questions for Ms. Reed or Dr.?
Yeah, Mr. Chairman,
I think we can go on. Okay, I'm sorry.
I have one.
Delegate Sickles.
Nope. Yeah, I have one question about you said you were hiring someone at MCO/behavioral health something agreement. It sounded like you were at an outside support for the MCOs at one point, or you were. It was on a chart on a page, 3 pages back, 2 or 3 pages back. You went over it, but and one more back. No, one more, sorry. Okay, right there. June 2021, the MCO Behavioral Health SA Readiness Review. Could you mention that? What is that about again?
So those readiness reviews are really, we provide expectations for the MCOs and the Behavioral Health Services Administrator for how we want to see claims paid and how we want to see service authorizations processed in their systems. And this is really their chance to show us that those things are set up correctly and processing correctly in their systems before we go live on July 1, so that we can prevent claims and a backup of service authorization issues happening when the new services go live.
Okay, thank you. Great idea. Yeah, I mean, we get so many complaints about these types of things. Thank you.
I want to mention that, Delegate Sickles, that one of the good things to come out of this enhancement process is while we are within Project Bravo, we're enhancing and bringing forward these new services, it's allowing us that closer, deeper look at the whole behavioral health program and the way that we currently process those services now. So service authorization is a good example, and one that I'm sure you all have heard a lot of complaint about in regards to how the managed care organizations and the providers work together in that process. And so we've been doing some close looking and potential revisions of the service authorization process for the enhanced services, and are doing that collaboratively with all the parties involved to see if we can't make some tweaks and process improvements and pilot that through these new services and see if that works better for the system, because we can see where there are some glitches, where there's redundancies, and where we can probably do some process improvement. So, being able to bring in these services is a real opportunity for looking at all of the services in terms of processes.
Okay, terrific. Thanks.
Okay, I'm going to hand over now to Ashley Harrell, who's going to speak with us about the Addiction and Recovery Treatment Services Program.
Thank you, Dr. Ward, and thank you, Senator Deeds. So this is the Addiction and Recovery Treatment Services benefit, the Medicaid benefit, was in a response to our opioid epidemic that really started to escalate back in 2014, 2015. And we know that Medicaid members comprise a disproportionate number of people that are affected by drug and alcohol use and dependence. So expansion of the addiction treatment services through the Medicaid program was a key focal point for us to be able to address this epidemic. So I want to thank all of you, senators and delegates, with your support. We were able to transform the Medicaid substance use disorder benefit. So this slide here shows you that we implemented the ARTS benefit in April of 2017. about 3 years ago, where Dr. Ward and Laura are now with implementing the first 3 services with Bravo. So ARTS is the continuum of care. So we were able to expand many addiction services from outpatient, community-based treatment, residential treatment, and inpatient hospitalization. Virginia was also awarded the 1115 demonstration waiver through the Centers for Medicare and Medicaid Services. And this allowed us to use federal Medicaid dollars to be able to fund substance use disorder residential treatment services in facilities that had 16 or greater beds. And we just received approval from CMS to extend the waiver through 2024, and now they're on 5-year extensions. Next slide, please. So Virginia Commonwealth University is our independent evaluator of the arts benefit, and they just completed their 3-year evaluation. And so the next few slides, I'm going to highlight some of the findings from this 3-year evaluation. So you see here with the Medicaid expansion, individuals, we saw a significant increase of individuals that actually were diagnosed with a substance use disorder and able to engage in treatment. In 2019, there was over 96,000 Medicaid members with a substance use disorder diagnosis, including 42,000 that were eligible through Medicaid expansion. This represents a 62% increase in the number of Medicaid members with a substance use diagnosis from 2018, doubling the number from 2016. Next slide. Among the base Medicaid members, so these are the non-Medicaid expansion members, over 47% of members with a substance use disorder received some type of treatment in 2019, compared to 44% in 2018 and 20% in 2016. Among this Medicaid-based population, 66% of individuals with an opiate use disorder received some type of treatment for their opiate use disorder. This was compared to 61% in 2018 and 32% in 2016. And then the orange bar shows you the number of members that have alcohol use disorder increased from 15% in 2016 to 46% in 2019. Next slide. So Medicaid has not only, the changes within the Medicaid benefit not only impacted the access to care for members enrolled in Medicaid, but it actually impacted access to treatment services for all individuals in the Commonwealth. There are almost 4,900 outpatient providers who billed for an ART service in 2019. This is a 31% increase from 2018 and quadruple the number of practitioners providing addiction treatment services from 2016. We also have, we mentioned Dr. Melton. He had one of the strongest preferred OBOT practices in the far Southwest and helped us design our preferred office-based opioid treatment model. We had 0 in 2016, started off with the arts benefit with 38 sites, and we are now, as of today, 169 sites across the Commonwealth. We also had a number of substantial growth with the number of residential treatment providers, partial hospitalization, and intensive outpatient programs, as well as our opiate treatment programs that are licensed through the Department of Behavioral Health that are participating in Medicaid. Next slide. This slide shows you the number of practitioners that have their buprenorphine waiver and are able to prescribe buprenorphine, which is the evidence-based treatment for opiate use disorder. We had 500 prescribers in the Commonwealth in 2016, and this has increased to 1,133 as of 2019, which is a 127% increase. We also see some geographic coverage across the state has increased between 2016 and 2019 from 71 counties that had at least one buprenorphine practitioner to 91 counties with at least one prescriber in 2019. So that's a 68% increase. However, we still have work to do. There are 42 counties or independent cities that currently do not have a waivered practitioner. So that's some of the work that I'm going to talk about in a few slides. Next slide. Medicaid expansion has significantly impacted access to substance use disorder treatment. More than, especially with opiate use disorder, we've had more than 23,000 members receive medications for the treatment of opiate use disorder in 2019. That's more than double the number of those receiving medication for treatment of opiate use disorder in 2018. There was a 97% increase with those members engaging in treatment from 2018 to 2019, that without expansion, these individuals would not have had coverage for this life-saving treatment. Next slide, please. We are also seeing an increase in substance use disorder expenditures. So this is claims with a primary substance use disorder diagnosis. And even with the impact of COVID-19, we're still seeing the trends increase with claims. And this is by date of payment versus date of service. Next slide. However, our work, unfortunately, is not done. The Virginia Department of Health just posted their fatal drug overdose report in January of 2021. And this shows that the number of fatal overdoses in Virginia, currently a total of 2,242, was the largest annual total ever seen in Virginia. When looking at the Q2 and Q3 numbers from 2019 compared to 2020, we're seeing a 63% increase in fatal overdoses. And so VDH is stating that 2020 will be our worst year on record by far for fatal overdoses in Virginia. Next slide. So some things that Medicaid is looking at to address this epidemic is looking at, yes, Delegate Bell.
That last slide, is that something that we're seeing nationwide? In other words, are those numbers somehow make us an outlier, or is this something we're seeing everywhere?
This is something we're seeing everywhere.
Thank you.
You will see it in every state in the nation. So
is there anything more than speculation that ties it to COVID? That ties it to the pandemic conditions we've been in?
Senator Deeds, that's a great question. And I think that's some of the things that we're looking at. I know that there is some increases, definitely because of the state of emergency and COVID and the impact on individuals' mental health. But there's also the impact of synthetic fentanyl that is being brought into the country, and individuals that are not intentionally overdosing, but unintentionally overdosing. So that's some of the activities that are, and I'll share a little bit about our Support Act grant and some of the projects that we're doing through that to help look at what potentially is going on that we're seeing such an increase in the fatal and non-fatal overdoses. So some things that we're looking at are some priority areas to help us understand the addiction epidemic and the impact of individuals in the Commonwealth. Some of this is prioritizing the initiation and continuation of the evidence-based treatment, especially for opiate use disorder, and that is medications, buprenorphine, naltrexone, and methadone, that individuals have same-day access to these medications and that they're able to continue on these medications and don't have a break in service. Some other things that we're looking at is understanding the data and how we can target our efforts. So looking at member enrollment, prevalence of substance use disorder diagnosis, access to treatment, emergency department utilization, using the prescription drug monitoring program, and looking at are there gaps in prescription refills for medications for the treatment of opiate use disorder. We're also focusing on transitions of care. So we know that individuals, when they're transitioning from an institutional stay, are at higher risk for having a fatal or non-fatal event from drug utilization. So this is looking at hospitalization transitions from individuals who are incarcerated and re-engaging into the community, and residential stays. And then also looking at priority populations, those that are at higher risk for negative outcomes from substance use disorders. And so that's looking at pregnant and parenting individuals, those justice involved and reentering the community, and those also that are transitioning from an acute care or an emergency department stay. Next slide. So Virginia was one of 15 states that were awarded the Support Act grant. The purpose of this grant is to increase substance use disorder provider workforce capacity, and then looking at how we can support providers within the addiction treatment community. So the activities of the Support Act grant is to do a statewide needs assessment of treatment and recovery services, doing a strengths-based assessment. So this is something unique that Virginia is doing compared to the other 15 states or the other 14 states. And then building state infrastructure in treatment and recovery. Next slide. So a couple of the projects that we have through the grant, we have 2 contracts with Virginia Commonwealth University. One is with VCU Department of Health, Behavior, and Policy that's doing the mandatory statewide needs assessment. They're doing also a targeted member survey for experience, as well as buprenorphine waiver provider capacity to determine what we need to do to increase that capacity. And they were also working with VCU's Wright Center. And this is one of the unique projects that Virginia is doing. We call it a bright spot assessment, but it's really a strengths-based assessment to determine localities that seem to have more positive outcomes and what may be contributing to these outcomes to be able to replicate that in other localities. And then the Wright Center is also providing trainings for providers, determining the impact of these trainings, and then utilizing a data visualization through a program that they call Health Landscape. So that will help us look at the providers community compared to what are the outcomes, the health outcomes for individuals in specific localities. Next slide. So this is an example of what the Bright Spot activity is doing. So this is looking at Richmond City and looking at where we have the darker shaded areas on the right bottom are the number of emergency department opioid overdoses per 1,000 members. And then we're looking at the number of buprenorphine waiver practitioners in Richmond City area per 1,000. So we can begin looking at, is there better outcomes for individuals that have better access to care? VCU is also looking at other factors within the Bright Spot activity, and we should have something ready to report out towards the end of the summer, early fall. Next slide. Some other contracts that we have are with Manat Health and Health Management Associates. Manat Health, along with state health partners, are conducting work groups to interview and analyze policy options for Virginia in responses to that were introduced by the Support Act law. And then we've also contracted with Health Management Associates, and their work is strictly with the criminal justice system and Medicaid interactions. So the goal of this is to leverage Medicaid and those individuals who have a substance use disorder that are transitioning from an incarceration stay into a community-based setting. And so we're working very closely with Department of Corrections and the Department of Criminal Justice Services on these projects and implementing 2 pilot sites with Department of Corrections and 2 pilot sites with local and regional jails. Next slide. And the grant is also promoting the Bridge Clinic model, both in person and through telehealth. And what this Bridge Clinic model offers is same-day access to medications for treatment of opiate use disorder, followed by stabilization and linkage to community-based care. So some core components for a Bridge Clinic is 1, starting buprenorphine in the emergency department. So if an individual presents for a related or unrelated event but is identified with an opiate use disorder and is currently not on medication, that the emergency department initiate that and then engage that member to a warm handoff to a Bridge Clinic. So it could be with our preferred OBOTs. and then care initiation and stabilization through these community linkages. Next slide. So some other activities with our Support Act grant is that we have secured 2 contracts for promoting a virtual bridge clinic. We now that through the state of emergency, one thing we've learned that Dr. Ward had mentioned is the flexibilities around telehealth and that how that can positively impact an individual's access to treatment. So these are implementing 2 virtual bridge clinic models, one through Virginia Commonwealth University that is standing up a virtual bridge clinic from their emergency department and linking to their preferred OBOT, which is Motivate. And then Carillion Clinic, which has a very robust bridge model now. They're implementing their bridge model they're enhancing it through the virtual clinic. And something else Carillion is also doing is building a protocol that they'll be able to provide technical assistance and training to 4 other hospital systems that would be interested in seeing how they can implement buprenorphine in their emergency department and then link to community providers. Next slide. We had talked about the significance of training for Project Bravo, that we can have this, but if we don't have a provider community that is trained in implementing these services, that it's not going to reach its full potential. So part of the Support Act was meeting the needs of providers and this transition to telehealth. That the grant team immediately started offering provider trainings that covered substance use disorder treatment delivery through telehealth, co-occurring disorders, hepatitis C, HIV management, working with special populations, just a variety of topics. And since April of 2020, we have held over 130 webinars, reaching over 7,600 participants. Again, that's free trainings to providers within the Commonwealth, over 7,600 participants. So a lot of work that our team has done to hold these trainings. And this slide here shows you their efforts are still going strong. These are trainings that are currently being offered in the spring, and then we'll roll out with another series of trainings in the summer, and they'll be around substance use disorder topics. And so with that, I will pass it back to Dr. Ward for some closing comments. Thank you for your time.
Well, thank you very much. And I guess, Dr. Ward, if you've got some things to say, we'll take some questions after that.
Sure. I just want to thank Ashley and Laura for coming with today and highlighting all of the really incredible work our team has been doing last year, despite COVID. And I just really wanted you all to be able to hear about that from some of the folks who are on the ground.
Yeah, I didn't hear you very well. Maybe everybody else did.
Oh, no. Everyone's shaking their head. I just said thank you to my team, and I'm glad that they were able to accompany today so that you all could see them and hear directly from the ground the great efforts that they've put in over this last and very effortful year.
And it sounds like you've been very busy. Are there questions for Dr. Ward or Ms. Harrell? Okay, well, I appreciate very much your presentation. In the last few months, an issue has been raised. It's been raised and raised time again over the last few years about sheriffs sitting in emergency rooms, deputy sheriffs sitting in emergency rooms. And of course, I hear on a weekly basis from a lot of law enforcement in the communities where I am all the time. And so John Jones from the Virginia Sheriff Association is here with Sheriff Warren from Gloucester County and Sheriff Townsend from Lunenburg County. And they're going to make a presentation about what's going on, what their experiences are. And after they talk and during our work plan, I want to talk about, or during our work plan development, I want to talk about how we're going to quit talking about this issue and come up with some solutions, hopefully during the interim or certainly by next session. Mr. Jones. John.
Thank you, Senator and Chairman, and good afternoon, members of the commission. I appreciate you putting us on the agenda. You've heard a little bit of comment about this for the afternoon meeting, and I just wanted to tell you about some of the crisis, and we're really at a crisis point you can remember back a few years ago when we had a 4-hour ECO, then it went to 8 hours, then we talked about 12, then we talked about the bed of last resort, and we've talked about a 24-hour. Well, let me tell you what's happening, and it's happening statewide because the bed of last resort, they're on diversion. They can't. There are not enough beds, and I was a little bit depressed to hear that even the number of beds we have are going down. So what I'm hearing from my sheriffs, and I've got 2 of them here, and I can say they represent just about everyone. I'm hearing it from all over the state, but we've got some ideas. We want to tell you about the crisis, and we've got some ideas to present. So what I'm going to talk about are 3 items that I think if you would look at in terms of the American Rescue Plan, the budget, it will put a Band-Aid on law enforcement and as far as our involvement. And one would be, what's happening. We are having these deputy sheriffs to sit in emergency rooms no longer days or hours, but days at a time. I'm hearing sheriffs say they've had them sitting with patients. They have to change shifts, and they're being there 4 and 5 days. And if you can imagine a rural sheriff's office where you've got 1 or 2 deputies on, and then the sheriff has to figure out how he's going to service this and put deputies in the emergency room sitting with a person until a bed is found into the days, that's costing the sheriff's office and the localities a tremendous amount of money. And what happens often is it goes into overtime. According to federal law, when you exceed the number of hours, you have to pay the deputies overtime, and it's taxing on the law enforcement services that are available in the community. So the first proposal that we're going to talk about here briefly, and Mr. Chairman, you introduced this amendment for the Virginia Sheriff's Association back during the regular session. It was simply to provide overtime payments during the executive orders dealing with the pandemic. They keep in mind, these deputy sheriffs, they pick up the ECO, they go through the process, the TDO is issued, they're in the car with that person across the state, they're sitting with that person, and they're exposed to COVID all the time. I'm aware of 2 deputies that have died and 1 regional jail person that has passed away. And, we have such a high turnover, and we'll get to that in just a minute, but the overtime payments would at least help us put a Band-Aid on it. So, Mr. Chairman, I'm just bringing it up again, and members of the commission, if you get a chance, as soon as it can be addressed, there was an overtime amendment put in. We can revisit it. It was about $3 million the first year and a little less than $1 million the second year, anticipating maybe the end of the executive orders. So that's the first item. The second item is an emergency amendment to address the alternative transportation provider. And thank you, Mr. Chairman and members of the General Assembly that are listening to this, that appropriated the money for that. It looks like I'm looking at the numbers for the first 3 quarters, about 1,400 alternative transports were provided. And that's running about 12% of the total transports in the various regions. But they only provide an alternative for transport. So we believe that it would also put a major Band-Aid on this problem if the contract could have an emergency amendment to it and fund it to provide for alternative sitting with these people until a bed is located, instead of tying up a law enforcement officer in the emergency room or the hospital. Let the alternative transportation person do that. It would require an adjustment to the contract, and that would require more money, about $1 million the first year and about $1.4 million the second year. So that is recommendation number 2. And of course, my recommendation will always be here on number 3. Mr. Chairman, we've got an exceedingly high turnover among deputy sheriffs. And these last numbers I have, these are the latest numbers I have from the compensation board. In the jails, a 35% turnover, annual turnover rate. In the courts, a 21% annual turnover rate. And in our law enforcement officers, 27%. that's almost unmanageable. So what happens is the sheriffs, especially the law enforcement folks, they're recruiting. We're dealing with the ECO, the TDO transport issue. We're dealing with COVID. With these high turnovers, we recruit, we train these deputy sheriffs. We pay for their training. We get them on board, and then they go to another agency. And I would refer the members of the committee here to my presentation, which is online. One example of that movement to other agencies is these deputies are participating in what's known as a lateral transfer program. And we certainly don't blame the deputies. What happens is the sheriff will hire the deputies. They will train them. They'll send them to the academy. They become a certified law enforcement officer. And this Virginia State Police will offer a lateral transfer program and pay them a lot more money. We certainly don't blame the deputy sheriffs for leaving. But there's a list there, the most recent list of the deputies that have left. And it's 26 deputies in September of 2020 through September of 2020 for the lateral transfer laws. And that's just one example. They're not only going to state police, they're going to local law enforcement. They're leaving law enforcement and doing other things to make more money. The starting salary is going to be $35,149 after the 5%. So our recommendation number 3 is to help us reduce the turnover. And Mr. Chairman, I know you were short on time. I wanted to hit my 3 main points. One is, again, recapping, and I'm going to turn it over to Sheriff Warren, recapping the overtime for deputy sheriffs. Give us some help with that. It's hurting our budget. And number 2, the alternative transportation provider, expand their role to give relief while we're sitting, and then do anything possible to reduce our turnover. So, Mr. Chairman, I'll answer any questions you have. And next, go ahead.
I got those 3 written down, John, and I want our group to think about that, how we can help. But I'm not sure what Commissioner Land can do about the money. I want her to try to come up with some solutions in the short term if we can, because this can't wait on money.
I agree, and I appreciate that, and and I really appreciate your attitude and the attitude of Commissioner Land. I mean, I know what they're dealing with. Everyone's having a tough time with this, but we're providing law enforcement services, and it's being hit up pretty hard.
Thank you very much. Sheriff Warren, you're on mute.
Thank you, Senator Deeds and members of the commission for the opportunity this afternoon. I just want to speak briefly on what we're dealing with. It's not only in the Roanoke area, as we've seen an article about. It's statewide, and as John mentioned, we are in a crisis. As you're aware, we typically transport a person in crisis, which I'll refer to them as a consumer, to a hospital to be medically cleared, and to meet with a crisis counselor from the Community Services Board, or the only exception to this would be if our drop-off center is operational and the consumer meets the criteria for that. And we'll transfer their custody to that facility, and the deputy can return to their routine patrol duties. But regardless of where this consumer is screened, if they meet the criteria ultimately for a temporary detention order, it seems like the waiting game, I'll call it, begins. And I just want to share a few examples of not only here in Gloucester, but of a couple of other smaller sheriff's offices in my area. I'm a little bit larger on the Middle Peninsula than my neighboring jurisdictions, but it's all relevant because I deal with many more people in crisis than my colleagues do. So in January, just for an example, we had a 17-year-old female in crisis that we maintained custody of her for 91 hours. So to put that in perspective, I mean, that's more than 2 typical work weeks. In March, we had another individual that we held in custody for 70 hours. New Kent County Sheriff's Office, an individual for 28 and a half hours, another one for 68 hours, an additional one for 91 and a half hours. Matthews Sheriff's Office, much smaller locality, one consumer 40 hours, another 24 hours, an additional 34 hours. It's always bad during holiday weekends. And I already know going into it, we have Memorial Day weekend coming up. I know that we're going to receive an email from John Jones letting us know that the likelihood of delayed admissions to the state hospital over the holiday weekend is going to be extended due to lack of bed space. I mean, it's just an automatic. Keep in mind that the ECO is good for 8 hours, but can be extended once. Your temporary detention orders are good for 72 hours for an adult, 96 hours for a juvenile, and they can be extended once also. We really need some help with this desperately. So even if we aren't concerned with the thousands of dollars in overtime that we're having to spend on maintaining custody of these consumers, or the increased response time that ultimately our other citizens in need are having to wait an increased amount of time for deputies to respond because there's less of them on the street. And even if we aren't concerned with these consumers that are occupying bed space in our hospitals, we have to be consumed with ultimately I'll echo what Delegate Ransom said previously. We have these people in crisis that aren't getting the help that they need. And that's the biggest concern that we have. Most of the time, these consumers are handcuffed to a hospital bed during this entire stay. We do that because we have to maintain custody of them. We do that so that, oftentimes these people can be unpredictable. So to alleviate having to have multiple officers present, we'll handcuff them to maintain the custody, safety, and security of not only our staff, the consumer, and the hospital staff as well. And what I often fear when I think about these extended cases, do you think these people are likely to reach out again if they're in crisis after having to wait and go through the ordeal that they've been through? And I'll just give you an example. The individual that I mentioned that we dealt with for 70 hours, he self-reported to our hospital. We have a hospital in Gloucester. He self-reported looking for help. We sat with him for 70 hours. So imagine going to a hospital emergency room and needing treatment and having to wait there for 70 hours to get the treatment you need. It's crazy that we have to tell these people, just sit here and wait, just sit here and wait. Again, I thank you for the opportunity to hear us on this. I feel like we're beating a drum, but I feel like regardless of who you talk to and where we're located, you're going to hear the same story statewide.
Sheriff Warren, I live in Bath County, which has a smaller population than any of your counties you're talking about there. And just since the 1st of March, the deputies and the sheriff here have told me about 2 different situations where they sat in the emergency room for more than 3 days with people.
It's sad. It's a sad situation.
Yep. Sheriff Townsend.
Yes, sir, Mr. Chairman. I want to thank you for this opportunity, and I'm not going to continue to beat the horse from listening to everyone speak today. It seems like that we all realize what the situation is. I think that everybody understands. I am a small county just like yourself. A population of 12,000. I only have about 14 men on shift. I lost 5 men to transfers to departments. I've replaced 3. Gives you an idea how much of a strain it is on this office. And so we do have a drop zone. It's a temporary, it's an 8-hour drop zone because of the funding, which is Bush River and Farmville, just the outskirts of Farmville, which helps with the sitting some. But, those are some of the issues that we have to deal with. And speaking of time with the TDOs, we had one that lasted 6 days. And that was pretty stressful on this small office. So I would just say basically that we're dealing with the same issues that you've heard pretty much everyone speak about. And I'm not going to rehash all of that, but I just want to thank you for this opportunity.
Thank you so much. Does anybody have any questions of Mr. Jones or either of the sheriffs? If when we talk about a work plan, I want to put some effort into this issue this year. Okay, if nobody's got any more questions, we're going to go right into our discussion of work plan for this year. Sarah, have you laid out some things for us, or you laid out some ideas?
Yes, Mr. Chair. So I sent you the document. It's similar to what we actually had last year, built off what we looked at the beginning of last year. Our time last year was really impacted by a lot of events. So I've sort of put some themes on there that you all seen before. I won't go through all of them, but the state hospital bed crisis and the response tends to be the number one issue that we've looked at and dealt with over time. Sort of some long-term pieces around implementation of STEP Virginia and behavioral health enhancement, and various other pieces there. We also have a couple bills that were referred to us. There were several referred during the 2020 session that we simply did not have the time to take up last year. One of those was Delegate Subramaniam's bill looking at implementation of deflection to treatment programs. Also, Delegate Adams' bill around mandatory outpatient treatment criteria, which is different than what we looked at with Delegate Hope's bill. There was Delegate Watts' bill around the expansion of who may do the TDO evaluations, and then the licensed inpatient nursing services in-home follow-up care bill from Senator Kiggins. Finally, we had a bill in 2020 from Senator Donovan requiring the Department of Behavioral Health and Virginia State Police, or would have required them to look at mobile applications around mental health and public safety. And Senator Deeds, you had Senate Bill 1049, which would have looked at notice and participation of family members in the involuntary commitment process. Those are sort of still pending before this joint subcommittee. And then during the 2021 session, there was one bill referred to the joint subcommittee. That was Delegate Cox's bill looking at release of a person who has been involuntarily committed prior to the expiration of their order. And he identified some specific cases. So those are before our joint subcommittee. We can weave those into any other work you'd care to focus on. It sounds like you have an interest in establishing a work group or asking one of the work groups to focus on the question of law enforcement involvement in the involuntary commitment process and how
what I was thinking about was just maybe getting 2 or 3, 4 people separate from the work group process itself to just be able to sit down with Mr. Jones, with John, with Commissioner Land, with whomever it takes, and try to come up with a series of recommendations for action we can take in the interim or certainly by next session to address this issue, because as the sheriffs have pointed out, this is an acute issue in some areas of the state. Probably it's an acute issue all over the state. And I'm just thinking we could have, I'm not sure if we really need a full work group. We just need 2 or 3 people to just kind of sit down and make sure that we have a series of recommendations for this. And this is something Delegate Ranson's talked to me about extensively. If there are a couple other people that are interested.
Mr. Chairman, I am absolutely interested in working with John on this issue.
Okay. Are there a couple other people that are interested?
Patrick Hope, I volunteer, Mr. Chairman.
Okay.
Yeah, I'd be willing to participate, Mr. Chairman. Mr. Chairman, I have a question.
Okay.
Both of the sheriffs mentioned drop-off centers. And, do we have a good inventory? We have one in Williamsburg that was wildly successful and at capacity almost immediately. Do we have a good inventory of how many we have across the state, where they are? Is that a worthwhile effort, or is it a pipe dream in areas like where you live?
They're a great idea. If you can, we don't have much of an inventory of drop-off centers. That's the reality. Isn't that true?
I would guess. I just wondered if that was a path we should take, but I don't know if in your part of the world it's ever going to be a real.
I don't think it's a bad idea.
Senator Deeds, we can work with DBHDS and other stakeholders to see if we can come up with a sort of organized list of where we have those types of programs available and how they fit into our existing program. That's something we could pursue.
Okay. There, at all of these topics, as I see it, all of the topics carried over from 2020 have some urgency. I want to make sure that we we press the administration to complete the implementation of Step Virginia in the budget. I want to see a plan for that. All of these issues are critically important. What is your pleasure? I mean, we could just take these issues and take the bills that have been referred, take the responsibilities that have been referred, as Delegate Watts pointed out, and the bill that allows evidence to come in of mental health and criminal trials. There is certain responsibility referred to this joint subcommittee, that so we can figure out which work group would be better to handle that, and there may be other responsibilities in other parts of the other bills. We can just slot those among the existing work groups. Does that make sense?
Yeah.
Does anybody else have anything specific or anything different that we need to be talking about?
Mr. Chairman, I just hope we get a price estimate on each of this, because I'd like to really get them implemented.
Well, Senator Howell, I appreciate that very much. I think it's extraordinarily important that we have an accurate estimate of the cost of each thing we want to do.
Thanks.
You are absolutely correct, though.
Mr. Chairman, if I could also, Delegate Price, thank you. If I could also say, and aligned with that, just re-upping the conversation about any of the funds that are coming from the federal government, if we could just get an assessment of what might help offset some of those costs, or some of the issues that were raised today. Some were at least tangentially effective because of COVID, or COVID affected it. So trying to see where we can help with that too.
Yes, I think you're absolutely correct about that. We have to be awfully cautious about building those dollars into our bottom line, so they create a continuing obligation, and we want to stay away from that if we can.
Mr. Chair.
Delegate Bell.
So I am looking at the makeup of the body and delighted we have more appropriators and finance people than we used to. I think that's probably a good thing. I'm conscious of us not doing something that treads on somebody else's toes or is duplicative or not wanted. And I'm going to throw a couple of ideas out there, but it may well be that the finance and appropriations people say we don't need any more advice on that. We got plenty. We have heard about this TDT, Therapeutic Day Treatment Program. I'm looking at Sickles. My understanding is that's going to be taken up by your special commission, and maybe therefore that's not something that this group would add much to if we did it. And then, Mr. Chair, it seems to me that we keep hearing, we heard today from several people who said that the lack of capacity at the hospitals is itself causing significant, I don't know if it's upstream or downstream problems. In other words, that by not having places to go, then the officers have to stay and maintain some sort of continuity. My recollection is last year or 2 years ago, there was kind of a decision made that we didn't want to open up any more beds because that seemed like a dead end. Maybe that needs to be revisited or not.
Delegate Bell, we always, I think we ought to be open to revisiting any decision. We ought to constantly be thinking about ways to improve the system. Here's has been my perspective on hospital beds. Nationwide, states spend about 70% of their mental health dollars on community-based services, 30% on institutional care. Virginia historically has spent more money on institutional care than on community-based services. I think all the evidence we've seen suggests that we can treat people more efficiently, more humanely, and more effectively through community-based services. We're going to need institutions, but my sense has been if we're going to put more dollars in mental health, I would rather put them in community-based services. I would rather find a way to more efficiently treat people and more effectively treat people that way. I may be incorrect, and people may disagree with me and vote me down, but that's kind of where I've been.
Mr. Chair, might I ask a question based on that? It seems to me that both of these spaces, the TDT program that was phased out before the new program was in place, And the shortage of hospital beds when everybody thinks community services would be better, but they're not here yet, kind of raised the same issue, which might be that we're sort of in a transitional period, but not there. And so the result is, at this moment, you've got deputies, stuck in hallways for 96 hours or whatever the numbers are. Really, I'm not actually trying to raise the issue here. Just if that is, it seems to me that's largely going to be a resources and money issue. If that's true, either bringing in all these finance and appropriations people is great, and we can debate it here, or they may have other venues that are better situated, and we should stick to our knitting where we have some expertise that can add to the conversation. And that's that. I think I've said enough, and it's time for some people in the majority party and the different to kind of decide this of what they think would be constructive for us to spend the next year doing.
You are raising important issues,
Mr. Chairman,
that go to the crux of the situation. We have to figure out, in general, our view has been, I think, or my view has been that we've got to figure out a better way to bring the private hospitals to the table, and utilize the private beds to a better extent than we have. I'm sorry, I was cutting somebody off.
Mr. Chairman Watts.
Delegate Watts.
Thank you. A corollary to this discussion has to be what was pointed out, the problem of direct care staff and the problem of compensation. That has to be addressed, and I put it right with this discussion because while there, as it has been rightly pointed out, there's been just heroic efforts throughout the last year to deal with this. Nevertheless, when we're dealing with individuals that are being stabilized and hopefully given recovery skills that can make them function in the community with the kind of support that you're talking about, the lack of staffing in our hospitals, not the additional capacity, but the capacity represented by staff who actually give care to the individuals, is something that we can't lose sight of when we have the kind of numbers that were shared with us, 20 to 50% staffing shortages.
You are absolutely correct. We've got staffing shortages across the board, but honestly, there's staffing shortages in the private healthcare world too, not just our state facilities. And in our CSBs, there's staffing shortages. I've heard that from Region 10.
Compensation is part of the problem. It's not just available. Those that have been available are leaving in part because of compensation, but I would say also in part because the downward cycle of the more who leave, the worse the work conditions are for those who remain.
Is George Barker still on the call? George was involved in a workforce related study. I think that the structure and financing group is probably among the work groups we have is probably the place to take a deep dive on workforce and consider ways to supplement compensation. But you're absolutely correct. That's something that needs to be looked at.
Mr. Chairman.
Delegate Sickles.
Yeah. Going back to the appropriate use of certain services, and I think Dr. Ward addressed this some in response to Delegate Bell. There was obviously bills in a study resolution to look at the MCOs and how they have cut back on therapeutic day treatment. You notice that there are intense efforts underway now at DBHDS to find what a evidence-based service looks like. We have to get to that first. TBT has been prescribed randomly around the state. In some places, kids that don't need it are getting it, and then in other places, they don't have it at all. and haven't discovered that Medicaid is out there to help pay for it. And the MCOs are trying to get their arms around this, and they need our help. And that is why it's a real step forward to have a behavioral health resolutions council that's meeting. You can't legislate this stuff. You need to have cooperation between the payers and the providers. That we don't have good enough cooperation, communications, and they're working on that hard. These are tough issues, and that's what part of our joint oversight is going to be about. Senator Barker and Mike Tweedy are looking for dates now to have that, but we're going to be talking about this similar issue in the oversight of how the money's spent. And me personally, I'm glad to see that the agency is moving out to try to address these very complicated issues. So, today was some good news for us. And if Dr. Land wants to follow that up with, Dr. Ward wants to follow that up with any other further remarks on that, I'd welcome it. But Delegate Bell, your question was kind of answered earlier in those slides, it seems to me, a little bit anyway.
Mr. Chair, Madam Chair, I'd be happy to respond.
Dr. Ward, sure. We're always willing to hear from you.
Well, in response to what Delegate Sickles just summarized into Delegate Bell's comment, can you hear me? I'm leaning into my mic.
Okay, we can hear you now.
Got to move things around here. What I'm hearing is Delegate Bell trailing a string between the utilization of therapeutic day treatment, which notably is a service used by largely young children, to the overcapacity in our largely adult population hospitals. So while these are two separate issues that do exist and need attention in our system, I don't believe that there is a relationship between the downturn in TDT services and problems with TDO or hospitalization directly.
Mr.
Just
Chair.
want to make that point. And correct me if I'm wrong, Delegate Bell, if I'm making the wrong interpretation of your comment.
Mr. Chair, I only drew those two together to try to say there are issues that may be appropriate for us to look at and issues that are not. I think that they both raise analogous. Now, I'm not saying there's any relation between them, just in both cases, we are trying to move to a better, more holistic approach. There is some evidence that we're not there at the moment, and how do we set up a proper bridge? But really, I was just trying to address your question about what we should be looking at, and I don't want to duplicate effort that's being made better in another place. If we can add value, then I'd like to do it. That's all. I wasn't trying to draw a connection between the two.
Thank you for your clarification, Delegate Bell. That's helpful. And I would agree with you that they both need attention, but they're separate issues.
You're muted.
I apologize. Are there other issues that people want to raise for us to work on this year?
Mr. Chairman, Delegate Hope.
Delegate Hope.
Yeah, I just wanted to recognize, obviously, the bandwidth for staff and what we're able to accomplish this year, because there's certainly a lot of carryover and a lot of issues need to be addressed. I do want to bring up the topic of mandatory outpatient treatment. I know that's out there for the reorganization, not so much the policy discussion as much as the reorganization. And maybe I could defer to Sarah, and I don't know how much work would be related to the commission to be involved in it at this time, but I just want to understand if there's sort of a thinking that we could at least not lose sight of the importance of the reorganization of those sections of the code.
Mr. Chair, we can do whatever it is you as a commissioner are interested in doing. Certainly. Delegate Hope, I think we've done a lot of the groundwork on that matter. And It's not something that would require a lot of work group or commission attention up front. I think as we got towards the end of the year, we might want to look at like a draft and that kind of thing. But if you're interested in continuing to pursue that, we are certainly happy to work on that.
Okay.
Sarah, let me understand if, as I read this thing on the list of topics, you're not really interested in making substantive change in that area. You're just interested in making the code sections more legible, more understandable. Is that right?
Yes, and I don't want to speak for Delegate Hope too much, but we did a lot of substantive work last year.
Right.
One of the things we know going into last year, and we sort of had to move on from this due to some of the limitations of time and the ability to get work done, is that the mandatory outpatient treatment statutes, when you look at those 4 sections, particularly the main one, like a lot of code sections, it started out doing one thing. We've added to it over the years. We've changed it. We've changed direction. We've added 4 different kinds of outpatient treatment options at this point, it feels like. And as that code section has grown and the related code sections have grown, we are concerned that there are some disconnects when you work through the fine details. And also it's unwieldy and kind of confusing just to read and try to understand how the pieces work together. So it is an opportunity to do some cleanup work. It's sort of like a miniature version of a recodification where we have the time and the ability to go through and break that apart and make sure that the code is clear, not just to those of us who work in it every day, but also to somebody else, citizens, attorneys, whomever, who may be using those code sections. So it's more exactly that, a process cleanup. It's not a substantive change, or shouldn't be.
Well, I want to make sure that both Delegate Hope and Delegate Bell have their finger in that pot, because they've both been adding to those code sections for a while. Okay, are there other work plan related issues? Well, if not, we're almost near the end, but we're not there yet. We still have public comment, and we have, I think, 24 people signed up for public comment. So what I would like to do is ask those people to keep their remarks limited to 2 minutes. And I would suggest that if each one of you take 2 minutes, that's almost another hour. And I don't know that I'm going to keep my quorum for another hour.
Mr. Chair?
Yes.
We have had several people drop out. So if I can make a recommendation that anybody who is still in the room and would like to speak, if you could raise your hand digitally, and I will bring you into the room. So as it stands right now, we've got a couple of hands raised. It doesn't look like we're going to do the whole hour.
Okay, well, let's do 3 minutes, no more than 3 minutes each.
I'm going to bring in Jennifer Faison.
Welcome, Jennifer.
Hi, good afternoon, Mr. Chairman, members of the committee. Jennifer Faison. I'm the Executive Director of the Virginia Association of Community Services Boards. You'll be glad to hear I do not have any prepared remarks this afternoon. I just wanted to let you all know that as you continue your deliberations, to feel free always to reach out to VACSB or to your local community services boards. I know that the commissioner went into great detail with you all today about some of the challenges and opportunities in the state hospital system, and is looking forward to briefing you further on community services. And we are happy to be a part of that conversation to the extent that you think that that would be helpful. And then 2 quick things I wanted to touch on. One is that the DBHDS actually has a report, I think it's from 2020, that talks all about CTAC. Sarah, this is for you. And it has like 3 options for expanding them. It talks about data around utilization and all that. So I think a lot of that work is done for you already in looking at those drop-off centers. And then the other thing I would say is that Senator Deeds, you did mention that, you think that community hospitals and bringing them in further is a good way to kind of balance that need for hospital beds with the transition to more community-based care. And, Commissioner Land did mention that there are a couple of pilot programs underway. And so that would do for discharge and diversion from state hospitals to private hospitals are going to be like on a contract basis. So I would be curious, and I'm sure you all would share my curiosity with what are the outcome measures that DBHDS is going to put in place for those pilot programs, so that you all can make sure that the funding that's going to is actually achieving the stated objectives. I'm sure I'm not saying that it won't, but I think if we can make sure that those metrics are clear up front, you'll have a better idea of whether those kinds of investments are the kinds of investments in local hospitals, community-based hospitals that are going to really make some difference in terms of reducing that state hospital census. Thank you all very much.
Thank you, Jennifer. Who's next?
All right. Next, we have Stephanie Williams. And after Stephanie Williams will be Anna Mendez.
Stephanie Williams, welcome.
Hello?
Stephanie Williams, you can go ahead.
Thank you for allowing me to speak today. I believe everybody received a letter that I sent to the committee about my personal situation with a family member who has suffered with mental illness for 20 years. For the families, we're on a completely different side of the story. We are not allowed very much input into care for a mentally ill family member. My greatest problem is with HIPAA. I know that's not your forte, but it has allowed the mentally ill person to make decisions about their own care. And if they refuse care, and if they refuse medication, there is no redemption of health. When a mentally ill person is obviously not connected with reality, and you hear them speaking about talking to kings and queens in the third heaven, you know that person is mentally ill. When you have in their medical history that they've had an admission to Catawba for almost a year, and they were diagnosed with bipolar illness with psychosis, you know that person needs medication. If the system does not develop a way to get mentally ill people medication, they are not ever in their right mind to agree with their own physical or mental health. My brother has been to a hospital in Allegheny County that will not call in a CSB representative because they have their own psychological hospital in Salem and they do their own psychological review. My brother has shown up at that hospital many times in the last 2 or 3 months. He is assessed by video, by psychiatric professionals, and he is assessed as being sane and has been sent out of the hospital with the clothes he is wearing, no money in his pocket, and no call to his family. I know that there are great problems that have to be solved to get these kinds of issues resolved. And I know there are people with big enough hearts to do it. I've received calls from community board representatives asking for my help and aid in doing things that they can do legally. I've had calls from his Medicaid coordinator asking me to please call a hospital and request CSB be brought in because they will not do it. And that is his local hospital in the Allegheny Highlands. Right now, our family has not had any idea where he is. We don't know if he's well. We don't know if he's sick. Unless he shows up at a hospital, if those two people had not called me, we would not know condition. It's great danger. He was recently discharged from Eastern State Hospital to wander Williamsburg and Newport News without anyone knowing where he was. That was information I received from a CSB worker. Now, the family, I don't mind the family being considered, but my question is, if a mentally ill person cannot be forced to take medication, then what kind of mental health future are we discussing here? Thank you for listening to me. I appreciate it.
Thank you for sharing your views. and I share your frustration. Who's next?
Mr. Chair, we have Anna Mendez and then Jenny Shatine.
Now, I thought we only had two hands. I guess they keep multiplying, huh? Ms. Mendez, how are you?
Thank you, Senator Deeds. I would like to let Senator Howell and Delegate Watson, I think also Ms. Williams, know that Health and Human Services is currently soliciting feedback regarding meaningful change to the HIPAA statute that would improve information sharing and care coordination in case management and facilitate greater family and caregiver involvement in care. So if people are interested in providing public comment, or if this work group is interested in pursuing HIPAA, there is currently activity and energy at the federal level to make some of these changes. The second and last thing that I would like to say is at Partner for Mental Health, we are not at all philosophically opposed to hospitalization. We absolutely believe that it is a, at times, necessary and life-saving intervention. I also want us to remember that Virginia is currently the state with the third highest rate of per capita inpatient psychiatric beds in the nation. So by that measure, if building more beds was going to be the thing that solved our problem, I do feel like we would potentially have fewer problems to solve in this moment. So thank you all. Thank you all for your time. Thank you to Delegate Hope and Delegate Bell for their amazing work on mandatory outpatient treatment in this recent session. Thank you to Delegate Price for your work around data sharing with the criminal justice system, which is incredibly important. And Senator Deeds and Delegate Watts, words really fail to adequately describe our thanks to you around SB 1315. Thank you both very much.
Thank you. We have time.
Hi, good afternoon, Senator Deeds and Commission members. My name is Jenny Skatine. I'm with the Disability Law Center in Virginia. It's okay, don't worry. DLCV recognizes and is really thankful for the hard work of the Commission. As we move forward, I did want to urge you to make all efforts to include the perspectives of people with mental illness, including membership on the Commission and its work groups, particularly peers with lived experience in Virginia's mental health system. Similar to the Crime Commission and other commissions, inclusion of peers ensures that the policies are not developed without the full and direct participation of members of the groups that are going to be affected by those policies. It really allows peers to voice and share their experiences as allies and partners in the legislature. So again, thank you for the opportunity to speak and for all the hard work that you all are doing.
Thank you so much, and I'm sorry for butchering your name. Who's next?
My apologies as well. Mr. Chair, there are several other people in the room, and I just wanted to make sure that if they would like to speak, that they should raise their hand digitally, and I can bring you into the room. And no one has raised their hand, sir. So I believe.
Okay. One thing I forgot to point out with the work group, with work plan issue, Delegate Ranson, with respect to the issue regarding the sheriffs, if we are going to make a claim for any of the money that we have to appropriate this summer, we have to be pretty quick about that work. So I would appreciate you maybe kind of pulling people together and doing some talking in the next month or so, because we might have a special session. We will have a special session in June or July to figure out how we're going to spend that money. And so if we are going to make a request for some of that money, we need to be prepared to do so then. The other work groups, I expect, unless there's a request to do it differently, I'll expect the same people will serve on the same work groups. And I hope that they will meet probably 4 times each this year. Does that sound reasonable, Sarah? Okay.
Sure. We can make that work.
And then the regular, the full joint subcommittee would come together back, I guess, toward the end of the year. And by that time, we'll have handed it off to the commission. and we will have an executive director and more direction of how we're going to go in the future. Does that sound like a plan? Well, thank you all very much, and until the next time, I'll see you.
Thank you, Mr. Chairman.